Okay, so are you seeing the full screen slide, Jen?
Yep.
Okay, perfect. All righty, well, hello everybody. I'm really happy to have everybody here. We've got a number of people that are attending for the first time that have been associated with the project that we're doing. And I wanted to start out by really thanking HL7 and ONC and the collaborative process of making the resources available for the project that we're involved in. We really have started, John DeMore earlier today mentioned the importance of collaboration in everything that happens in interoperability. And that collaboration really hasn't been present within the specialty areas of medicine, especially the EHRs that serve independent providers. So this project has really had a pretty major influence on starting that collaborative process. So it's not just the mapping that we're doing that's important, but the overlap into a lot of other areas. Before we go into it much more, I just want to introduce Dennis Ball that's presenting with me. I'm an optometrist and my background is totally non-technical. And if you ask Lisa, you know, a bit how much knowledge I have in the technical world, she'll say none. But Dennis brings that technical knowledge to our team. So I'll just let him introduce himself. Dennis?
Yeah, hi everybody, yeah. Yes, I'm Dennis Ball. I've been involved in the health industry for about 30 years. I also worked on HL7V2 back in 1990 and bring a very diverse background in terms of technology and IT.
Great, thank you, Dennis. So just to sort of set the stage for what we're going to be talking about, I think one of the things that this project is doing, it's putting a focus on clinical data. And when we look at the core of USCDI 1, there was no clinical data there. So the early stages of interoperability, as far as referenced from the standpoint of specialty providers, didn't include any of that specialty information. And it resulted in, I think, kind of an attitude that sort of permeated specialty care, that, you know, the whole process of certification was more to get a check mark than something that had a whole lot of value to the users within the specialty areas. And, you know, there's not a day goes by that I don't talk to EHRs or providers that say, yeah, we tried using direct messaging, we tried getting C-CDAs, but, you know, the data didn't really help us much, and, you know, or there were technical problems with it, and, you know, we just stopped. And I hear that constantly. So this project is helping fill in that really missing core of mapping the specialty data to the C-CDA so that there is value at a lot of different levels. But when you start looking at that, one of the challenges that affect what we're doing in this program is how to consume that data and how you're not only just creating the C-CDA, but if you're going to use the information effectively, you've got to be able to consume it. And, you know, so when we went back to earlier certification steps, the consumption was just bringing it right into the workflow. But when you start, so that makes sense if you're doing a problem list or a medication list or most of the sort of one level type of data that's in USCDI 1. But when you get into clinical data and you have multiple levels of it and you have nesting and you have all kinds of other things happening, there's very valid reasons why you don't want to put that data into the workflow of the receiving end. You want to have it available so that they can easily access it, but it's not quite as simple, and it brings up a lot of challenges. And I think tomorrow we'll end up talking about some of those challenges. And just for a couple examples, when we're talking in specialty areas, let's say as an example, an optometrist receives a C-CDA through care quality, for example, and incorporates that into their record, then ends up making another referral to an ophthalmologist for surgery of some type, let's say. So is that core medical data that was embedded in the optometric EHR then put into the next C-CDA by the optometric EHR and sent to the ophthalmologist? Or is it better to have a 2 C-CDA process where the ophthalmologist goes out and gets the core medical data themselves through care quality, and then only gets the specialty data from the optometrist. Those are kind of different discussions, and I don't see those happening very often, and it raises some interesting questions that affect significantly how that data is consumed and how it's handled, when it's being consumed. So we had originally envisioned that we would have in day 2 tomorrow, that we would have a bunch of EHRs creating C-CDAs with a couple of example specialty data pieces, and then being consumed into the workflow on the receiving end. We found that there were enough challenges. We really need to kind of dedicate part of this process better understanding the sort of idiosyncrasies of consuming it when it's going to be used a little bit different and it has to be transmitted on. The other issue that's became pretty obvious is that when you get into specialty care, there's a whole bunch of data that very detailed data is needed within the specialty, but nobody else in medicine gives two hoots about that data. An example of that would be a primary eye care provider coordinating care with a dry eye clinic, where the dry eye clinic is quite a ways away, and some of the care is being provided by the primary care, but some of the specialty care that involves expensive equipment may be provided by the dry eye clinic. So the detail that they need to share is way more detailed than they're going to want to share with anybody else. And it's not detail that a lot of the established ways of sharing information contain at the current time. So again, we're going to get into some discussions that I think are going to be interesting and kind of present the opportunity to look at some of the things that we're doing a little bit differently. So when we define this project, the title of it is, especially data mapping. So we had, I'm an optometrist, Dennis is, primarily within eye care. Eye care stepped up to the plate with a lot of EHRs, a lot of people involved and very interested in getting involved. In other areas of independent specialties, such as dentistry and physical therapy, we found that there wasn't as much interest, probably for very valid reasons. Dentistry, for example, and we're going to hear a report from dentistry tomorrow that I'm going to be very interested in listening to, but they have a bunch of waivers that they don't even have to do what everybody else in medicine does. Their EHRs aren't certified, and their EHRs, for the most part, don't even support direct messaging or C-CDAs. So that's kind of a specialty area, and I'd be really interested to hear the presentation tomorrow. And physical therapy basically said that they really work off the care plan from the physician, and as far as any specialty data that they generate, that there really is very little of that kind of data. So what we found was with the independent specialists, there was a huge need in eye care. There's a lot of co-management for different things between eye care providers. There's a lot of referrals between ophthalmologists and optometrists. And there's a lot of information from eye care that primary care physicians and the rest of other medical specialists want to have. So what you're going to see in this presentation is it's really dominated by eye care. But what we're trying to do is set up processes that any other specialty within medicine can follow the same processes. So what we've accomplished in the project so far is we've mapped some high priority eye care data to C-CDA, and John Demore is in the process of creating some initial implementation guides. We think we're creating a process to identify and prioritize specialty data for future mapping that we're doing within eye care, but we think that other specialties can follow a similar process. We've probably most significantly, we've brought together the eye care EHR community really for the first time to work collaboratively on toward interoperability. And the response that we've gotten has really been pretty dramatic. There's one developer that I think he's on for this hour, but for the most part is spending the next 23 hours getting ready for the demonstration tomorrow. So the commitment is pretty significant that we've seen from some of the eye care EHRs. But we think that we want to be able to share this with other specialties that can follow the same model and do the same process. So to step back a little bit of why this interoperability is so important is if you look at healthcare reform in general, it really has three primary things. It changes from everybody just assuming their quality to actually measuring clinical outcomes through registries. It involves then being able to coordinate the care to improve those outcomes and to empower patients to improve those outcomes. But all of it is kind of contingent on registry data. So when you talk to providers that aren't using registries, all the rest of it kind of doesn't make sense. But to get the data that's needed for registries, you've got to have the communications working. So this communication step is a key to kicking off everything and giving everybody that needs to be involved the tools that they need to be able to do that. So just so everybody knows kind of what we're dealing with within the specialty areas, as of today, there are very few specialty EHRs that support the use of electronic communications. The EHRs involved in this project are really leading on improving that. And what we see as a result of that is most independent specialty providers are not using direct messaging. As a matter of fact, over the last couple of months, I've probably talked to 50 providers in different practices, in specialty practices. Not one of them are currently using direct messaging or any type of electronic communications. So, when we talk about we're putting together TEFCA and all this national communication capability, most of the specialty providers don't have access to that whole system right now. And what I find is everybody's still using faxes. So when I talk to hospital systems, they don't want to get faxes. But when I talk to specialty EHRs and providers, that's all they're providing. So there's a big gap there that we really need to overcome. And that's really what this project was designed to do. The other problem is a lot of EHRs don't have the ability to send some of the clinical data to EHRs to really start those outcomes. And all of this really has kind of prohibited or made it difficult for specialty providers to really get involved in the team type of delivery of care that is the core of the healthcare reform movement that's happening in the country. So as a result of this project, we now have a couple of the EHRs whose users right now are not doing any clinical communications electronically, have implemented most of this, and over the course of this project are at some stage in being able to do all of this. So relatively quickly, they're going to be able to go to their users and offer a completely different user experience in those EHRs. So it starts with no two uses a care quality infrastructure to get data. If you kind of look at the interoperability step, if your direct messaging doesn't work, getting that data in the C-CDA through the care quality network doesn't really help you much. So the first thing is there's integrations happening with care quality, either through No2 or other ways, Commonwealth. There's some of the EHRs are very close to having integrations so they can start getting that data for their users. When you look at secure messaging, a lot of the EHRs had only progressed to the point that they kind of met certification, but nobody used it, so they haven't improved it, and it might not be very user-friendly. A number of EHRs are currently working on the usability of the direct messaging implementation that they've put in place. Then when you look at the C-CDAs themselves, none of the C-CDAs up until this point have included any specialty data. So now we've got EHRs that are working on creating those C-CDAs. You're going to see some of them in the demonstrations tomorrow with a very limited amount of data, but we're putting the process in place to be able to really map a lot of useful data into the C-CDAs. And then the other part of it is getting the data into the C-CDA is one thing, but being able to consume it is a huge issue for a user to make the data usable. And as I mentioned before, there's a lot of issues with this that I think we'll end up discussing tomorrow, some of those issues and what has to happen to overcome those and have some consistency in the way that we implement the use and the consumption of those C-CDAs. Some of the EHRs didn't have the ability to include images. And, I think one of the core concepts of value-driven healthcare is to get rid of duplicity in healthcare. And I think in eye care, we have a great example of that, where an optometrist does a whole battery of tests, refers the patient to an ophthalmologist who repeats all those tests, 2 weeks later. So being able to transmit those, being able to transmit, how the to how the optometrist interpreted those images to the physician has a whole lot of value in developing that trust relationships that are so important in referral relationships. So we're seeing EHRs open up their capabilities to include imaging, and then being able to support registries. The IRIS registry for the Academy of Ophthalmology, healthcare registries. There's different registries that are out there that can get that clinical data. And just one of the examples of how that clinical data is sort of pushing the rest of this capability within the IRIS registry, they have found that they looked at the success of cataract surgery, and they found that when cataract surgery is not as successful as it was expected to be, in about 40% of those cases, there's dry eye, a component, which is actually affecting the quality of the surgical outcomes. Dry eye affects the surface of the eye, which affects the measurements of calculating the implant power, for example. So in about 40% of the cases,
for your dog to be long enough for your dog to do what dogs do, which is go explore.
All right. So that data has now sort of implemented a whole need within the eye care community that is really important. So when an optometrist has a patient that has dry eye, it's really important that that dry eye be properly managed before they're referred. The last thing that an ophthalmologist wants to do is have a patient in their chair and say to them, yeah, your cataract's ready for removal, but now we've got to manage your dry eye before we can do that surgery. So the coordination of care of that becomes really important, and the ability to have that structured specialty data to be able to coordinate that care is essential, or you can't effectively do that. So the way we went through this process, was there a question on that? Does somebody have a question? Okay. The way we went through this project is we started by identifying what data needs to be mapped. And there's a lot of data in the specialty areas. There's tons of data within eye care. So we went through a process to make sure that we were able to prioritize the most important data that would have value. So one of our goals was, when we completed this relatively short project, we wanted to make sure that it would actually impact the ability for providers and EHRs to change the way we do things within eye care especially. So the first thing we did was ask the EHRs that are participating to review the data that they allow their users to record, so that we're sure that we have all the data that providers are recording included in our data mapping process. Then we looked at the MIPS data. What we wanted to make sure that we had all the data that would be necessary for MIPS scores included in the process that we're doing. We also looked at the clinical guidelines that are published by both the American Optometry Association and the Academy of Ophthalmology, making sure that the terminology that might have to be shared for providers to follow those clinical guidelines is actually included in our data sets also. And the other thing that we did is there was a lot of work done quite a few years ago by IAG. They developed a document called the General Eye Exam. So we use that as a reference constantly, that when we can, it's the IAG structured things different than HL7 did, so we can't just use that mapping. But we use it, so for example, a lot of times there's questions about which is the proper code, the SNOMED code or the WINK code or whatever. When we can, we follow the original guidance that was done by HIE if it still makes sense. And that's especially important when we see like two choices, we think they're equal, we're going to go with the one that IHE decided was the choice that was most valid. So that's kind of the core of how we identified our data. Then of that data, which ends up with a lot of data, we had to really then decide, what are we going to map first? So what we decided to do is identify the most common communications within eye care and ask providers and EHRs, what are the most common communications that occur that we need to have the data for? So we really identified three. So when an eye care provider does an exam on a patient with diabetes, it's required that they send a report back to the primary care physician. So the data that's needed in that type of report is some of the high priority data that we've created for what we're doing in this project. The second one is when optometrists and ophthalmologists co-manage cataract surgery, CMS requires that the pertinent data that's found during those follow-up visits in the optometry office is communicated back to the surgeon. So we highlighted those, and the two pieces of information there that are most important are visual acuity and refraction. And there's also a whole lot of other use cases where visual acuity and refraction are important. So they became our top two items that we really concentrated on in this process. And then the third use case that we identified was what I mentioned already, the fact that coordinating the management of dry eye on cataract referrals, because cataract referrals are one of the most common surgeries in medicine. That's a very common surgical procedure. And when, of the failure ones, when 40% involve dry eye aspect, that became a really important issue that we're being asked to identify. So our top data points that we prioritized in the project was being able to put visual acuity, refraction, some dry eye information, and some diabetes information into the C-CDA. So that's how we prioritize that. And what you're going to see tomorrow is just sharing visual acuity and refraction. Those are the two things that we're demonstrating in the demo. So if you remember, if you attended last year's or the IAT earlier this year in April, in the breakout session, Matt from Epic, the person that has the last name none of us can say, and Dennis and a couple other people participated in starting the process of mapping some data and looking at where this data goes. And it was decided that the physical exam section is where this data needed to go. But when we went to it and looked at it, there was virtually no guidance and no examples. And it looked like basically nobody's been using, at that point, had been using the physical exam section of the C-CDA at any great extent. And there was very, very little guidance that was in place for that. Within the physical exam section, there's different templates. There's the physical exam of the eye, physical exam of the foot that had lots of different templates, but again, really no guidance on how to use these. So that's where I'm going to turn it over to Dennis now, who's going to make some comments about kind of the approach that we've used to start using these templates. And again, trying to set the guidance so that there's consistency in using any, if I go back to any of these templates, when somebody's trying to use any of them, we think that it should be a consistent approach. So Dennis, do you want to comment about where we are?
Yeah, thanks, Jim. Yeah, so obviously, yeah, the physical exam, like Jim had mentioned, hadn't been used. If it has been used, it has been very sparse and not very widely used in the industry. So obviously with eye care and many of the disciplines that follow like a evaluation management and coding philosophy, where they have to record all their clinical data, it has to be organized in such a way that we group all the clinical data that's related to the different structures of the eye, the way that they perform the exams, and it ends up being, result type of data that doesn't really belong in a results section. They're not lab type of results, but they're clinical results. And so without, having to go and try and create new templates or administrative templates for the C-CDA and the CDA group, it was, we wanted to look at existing templates that would fit. And so one of the templates was result organizer, result observation. So basically result organizer is like a battery of tests. So if you're doing a lipid panel, you'd group all the results in one. So we're using that pattern to group all the visual acuity data into, the correct place where it can be visually relevant and, communicated correctly. And as we went down that road, we also felt that we needed to do a bit of nesting. We tried to avoid nesting. We even attempted to use LOINC codes, and I think Matt might, as from Epic, might remember this. So we were able to find a lot of LOINC codes, but what would happen is when we decided to use a LOINC code, it would come up and say, well, it's a visual acuity, it's corrected, it's in the right eye, and it's using the Snellen chart. And that one LOINC code was representing multiple levels and categories for the eye care data, which didn't really make sense for the way that we were trying to organize it. And it would make sense in some cases, but for most of the clinical data, when you're looking at the different structures of the eyes, like the lids or the vitreous and the posterior segment, the anterior segment, these are maybe all terms that if you're not in eye care, you wouldn't realize it, but the structure and the internals of the eye, there's a bunch of different layers that have to be recorded and grouped together. And that's where nesting came in. And it's not, that also is an approach that hasn't been used a lot. So what we were doing is doing a result organizer for the first level, and then another result organizer for the second level. And then when you got down to the part where you would actually record all the results, you would actually, put that at the observation level. And that's what this is. Back to you, Jim.
Okay, so with that nesting, I'll just give you an example of where, at least from now again, I'm not a technical person, I'm a clinical person. From a clinical standpoint, for example, just to give you an example of where things have to convert. When you talk about neovascularization in the eye, those are blood vessels that grow that aren't supposed to be there. Well, you can have neovascularization of the iris, of the optic nerve, of the peripheral retina. You can have neovascularization of a lot of different structures, and the SNOMED code is going to differentiate those. But from an organizational standpoint, it could be within a completely different structure of the eye. And when you kind of like lump all those completely different things in the same section, it becomes really confusing to see how that works. And when you can nest it under the subsection of the part of the eye, that just makes it make a lot more sense and usable, at least certainly from a clinical standpoint. But from a technical standpoint, I think it makes it easier to do some of the processes. This is just, I'm going to have Dennis go back on this one and just talk about nesting in a little more detail.
Yeah, and then Jim gave thank you, Jim. You gave a very good example. So, I mean, basically what we're trying to do is we want to be able to organize structurally and visually the data that represents the way the exam has actually been recorded. And one of the ways we can talk about the nesting is like Jim was talking about, is diagnostic tests. So you have a bunch of different, maybe 20, 30, there's probably even more diagnostic tests that can be done for the eye. And then once you get into that diagnostic test, there's different level of tests like dry eye, cornea evaluations, dry eye questionnaires, assessments, those all come under there. And it's really hard to put that at a single level. And so the nesting is really, when it's appropriate, and not everything in eye care will be nested, but there will be a lot of clinical data where we have to do multiple result organizers so that we can actually structure that data in a relevant way. But it also lends itself to an easier way of consuming the data. So, when you're actually doing visual acuity, you have the result organizer, then you're getting the uncorrected section, and then you're going to read in all the data for uncorrected, then you're moving to the next organizer, which would be the corrected. So it just provides a natural flow in the way that you would represent the data and to actually consume and generate it.
Very good. So the overall project that we're involved in here really is a six-step process. So like I talked about before, we started by inviting specialty EHRs to participate in this. And in the process of the next steps, some of these EHRs took a really, really active role. I think when Dr. Perry introduced herself, she did a ton of work on helping to identify some of the data, and Robin that's on, she contributed data, and other EHRs contributed data from the review, not only from the review of their EHRs, but also going past that and looking at some of the other sources that I talked about, and really made a major effort to contribute to getting that data in for step 2. Then we prioritized it the way we talked about before, based on the common communications that were going to occur. Then I would, and my part of the team would go through and try to identify the proper LOINC code or SNOMED code, review the IAT, do that type of process, then turn that over to Dennis's part of the team, who would then pretty much break apart everything that we did and improve it from there and end up with the code that we're going to send on to the next steps. So, and I'm going to have Dennis on the next slide talk about, in a couple slides down, talk about the next steps that he's doing of creating the data mapping and the XML examples. And then it goes on to another part of the team that's creating the implementation guide. So in the identifying those points, some of the points, like we said, we looked at all of the guidelines, we looked at MIPS, and we followed the GEE. The common use cases we then used for the priority. When it came to the proper code, that's not as simple as you would think it is. If any of you have been involved in that process, you know what we're going to talk about. Dennis, do you want to comment about this step?
Yeah, that was a tough spot. I mean, in SNOMED is such a large, coding system. It's that, and it's been around for many years. Pathologists use it to, review slides, microbiology, all the different areas, and it's been around for a long time. So, Jim and team would go through and pull all the data points. They would try and put the categories together, but often, we might pick the wrong code. So it's important to make sure that when you're documenting the levels of the structure that you're doing it properly. So is it a structure of the eye? Is it a finding or a disorder? In some cases, when you're doing method codes to say how it was done, it could be a physical object, it could be a procedure or an assessment. So I have to go and take all the codes and the levels that Jim put together and organize that in a structured way that it can be mapped between the fields of an EHR and the data elements that we're actually putting in the structure. And again, we did use LOINC wherever we could to try and keep the LOINC as a consistent, but as we get into the clinical terms, LOINC doesn't have, the clinical terminology that often gets recorded, prisms being vertical or horizontal, and not including the method code in the eye so that it could be structurally consumed in a very efficient way. Next slide, Jim.
So it's important to add to what Dennis said that we have a way of properly communicating, right? So when we would identify a code and send it, and then Dennis would say that he changed it, our response is, don't hold us responsible. We're just damned optometrists.
Yeah, well, I mean, and it's important. I mean, we did use guides, like, again, we're following the HL7 procedures and processes. So the IHE guide for the general eye exam was used as kind of a reference. And when it made sense for some of the stuff, it did, we used it. When the codes didn't make sense, then we looked for alternatives. And, that was created back in 2016. A lot of codes have been changed and modified since then. So then once we get the codes, I take the data, and what I'll do is I'll create like a mapping structure, and that mapping structure will actually document the levels, whether it's an organizer or an observation. It will document all the data points that are recorded in most of the EHRs, and I'll put a code to that structure. And so we pull those on, and as we're creating that data, I'm also creating value sets. So for instance, if you're doing a refraction, there's different ways to do a refraction. It's subjective, objective, cycloplegic. So we're creating a list of value sets at the different levels. So there's 12, areas of the eye. There will be a value set that shows the codes that we've put together for those 12 areas. And then for each of those categories, and so on and so on, we'll create these value set structures, which, may change over time. And we don't have all of the codes. There are still some codes that we may need to look to get added through LOINC or SNOMED. So then I'll take those and we'll create a view that's relevant for the report of the communication and question. So for instance, we want to make sure that if you're doing a referral note, the way that you organize the sections and the way that you put the required sections for a referral note, we want the reason for referral at the top. We want those sections ordered appropriately. So when the doctor receives the C-CDA with the style sheet, they can actually review the data in a way that's going to make sense and be very relevant to them. Problems and medications, allergies still important, but the reason that the referral's being, done should be at the top. And then what's been asked of the ophthalmologist or the optometrist on, perform a diabetic exam. So the HTML structure is is important to make sure that we're putting it in a nice way. And I think it was mentioned before when you're doing the fire mapping, those style codes. And I think that's important, that these codes also be mapped from CDA to fire in a very common or appropriate way. So then I'll take that data, we'll create the HTML output view. We'll then, take the XML, I'll create an example around it. I'll put as much notes and documentation in as I can to create an example that's relevant to the use case. So in one case, it would be a diabetic report progress. It could be an operative note. And then, of course, that would then get submitted to John. So the next slide. And this is the part that John has been, overseeing. There's a lot of oversight from HL7, making sure some of the deliverables are going to be the data maps. It's going to be some of the examples to do with the types of communications. Primary care physician is referring to an optometrist. The optometrist sees something wrong with the eyes, needs to get an evaluation done, an ophthalmologist. You may refer them to diabetic educators. There's all sorts of different communication levels, but ultimately we want to come out of this project with the start of an implementation guide that's specific to eye care. So this is the first version, which has some of the visual acuity in it initially, and refraction, dry eye. Some of the posterior will be some of the sections that we'll be adding next.
I just want to add one thing to what Dennis said about the proper form of the C-CDA. Right now, with the limited communications that do occur within eye care, at least, the C-CDA type that's being sent is pretty much the exam summary report. And when that's sent, there's no context around it. The person receiving it, without going into the details of reading it, with a quick glance, can't tell why they're even receiving that information. Whereas when a proper referral is made, and the purpose of the referral, who it's coming from, who it's going to, is right in the header, you have that context to know why you're getting that information, and that's critical for usability.
It is. Yeah, you can add obviously a PDF or an attachment or something to describe what the referral is for, but you start having to add multiple attachments, images. It just makes sense that the CCDA can support it. It's got the reason for visit, the reason for referrals, and all the assessments and the plans. If those get communicated, it's more efficient for the providers.
So where we
Jim, are you going to be, oh, sorry.
No, go ahead, Lisa.
I just was wondering if you're going to be taking another time, or at what point will you be talking about distinguishing the different types of C-CDA documents and the importance of using the right document type for the right type of communication?
That's a really important issue overall. What we're trying to do is write the guidance to be able to put this information into a C-CDA, regardless of which format of the C-CDA you're using. So it's a little bit different discussion. I think it's something that we could enter in tomorrow in a breakout session, because that's one of the key things that we want the EHRs to do, is start using the proper form in the proper time, and them understanding that some of them aren't even aware of all of the different forms of C-CDA that there are, and very few actually create the appropriate type of format of a C-CDA for the appropriate use. But that's a really important issue, Lisa.
Yeah, that's a good point, Lisa. It's to just add to that a little bit. So, obviously in optometry and for certification, there's different documents that we had to create. So there's the referral note, but in most cases, you're going to be doing a progress note, an op note, or a referral. And we just want to make sure that those sections they're done appropriately at the right time. And so, previously, Lisa, if you remember with Project Claire, we did start some of that where we put the document types, but not only did we put the document types in the required sections, we also ordered those in a way that would be more relevant and efficient for the providers.
So the other thing that we're hoping continues is this collaborative relationship that started between the specialty EHRs, especially eye care EHRs. We know that some of the EHRs, and actually while we've been on this meeting, I'm watching some emails, and we've got some of these teams are coordinating, sharing information right now that have never talked to those other EHRs. So we're hoping that we've started that process. But also, this, when we go back to healthcare reform, what we're really doing is talking about a transformation in the way we develop healthcare. And that has to be led by the EHRs to give the providers the technical capability of doing it. But the providers are the ones that are actually changing the way that they deliver care. When you have clinical outcomes from a registry, when you have the ability to coordinate that care, when you have when you see how empowering the patient to be part of that care team is critical to improving those outcomes, you can't see that without all of this coming together and actually working. So the providers out there have actually lagged behind in being able to really be part of this whole transformation that the rest of healthcare is really pretty far down the road in doing. But yet, fortunately, we have some providers in kind of leadership positions that do understand it and are really pushing for this, both within their own practices and within organizations that they belong to. There's two on this meeting, and I would just like to really hear from them. Gretchen Kimball, do you want to make a few comments about your office and the importance of these type of communications? I don't know, maybe, can anybody tell if Gretchen is logged on?
She isn't. There is no Gretchen on right now.
Oh, okay. I sent her the login set. How about Thomas Brown?
Hey, Dr. Grew, I'm here.
Hi, Thomas.
Hey, yeah, I will briefly say that, I think our doctors are excited when I tell them about the potential that you guys are working so hard to create. They're looking forward to this technology being available to them. There's, in the world of ophthalmology, not to make this story too terribly long, but we are basically losing 50 ophthalmologists every year due to some of the actual results of the Clinton healthcare reform plan. So for the last 10 to 15 years, we've been losing on average 50 ophthalmologists every year. And so what we're starting to see is ophthalmologists moving to the coast, East and West Coast. And for the ophthalmologists that are remaining, I'm in Memphis, Tennessee, the ophthalmologists that are remaining here in the center part of the country, we are seeing an incredible increase in the number of patients that need to be seen, but an incredible depletion in the number of ophthalmic providers that are able to take care of them. As such, we're needing more and more of the ability to coordinate care with the larger eye care community and to work together with that larger eye care community. Diabetic patients. Diabetes is a condition that is rampant in the Memphis area. There's probably close to 200,000 diabetics in this metropolitan area, and we have fewer retina providers here than we had even 10 years ago. And there's no way that our retina providers by themselves can take care of all of those patients. And so the desire has been to use the larger eye care community, the optometrists in the community, and let them manage a lot of the day-to-day maintenance of these patients, the routine care of these patients, and then use the surgeons for those that are developing pathology and need special medical and surgical needs. But we still have to have that ability to sort of track our patients. And our surgeons are excited about this technology because it would give them the ability to track their patients while the patients are being seen in optometric practices, so that we can work together with the larger optometric community to take a population of patients like those 200,000 diabetic patients and identify the 10% of those patients that are at risk of developing diabetic retinopathy based on algorithms and artificial intelligence, and coordinating so that we can focus our treatment efforts on that 10% rather than taking a shotgun approach at the full 100% and trying to manage all of those patients. But to do that, we have to have this ability to send and receive data on our patients and to be able to record that data within our own EHRs. And with Dr. Gru's help and Dennis's help, we've been able to work with a registry, and we have been able to capture some of that information from some of the optometric practices within our community. But we are looking forward to the day that this becomes something more, I guess, ubiquitous among healthcare providers and the EHR systems out there, so that we have that greater access to it. Same way on the cataract side, because we have a decreasing number of providers on the cataract side, we are delegating more and more responsibility for post-operative care to the larger eye care community. But to do that, we still have to be able to get the information from the larger community on post-op results and things such as that. And again, that information, we are at this point, we do have a few optometrists that are connected to a registry, and we're able to get information through that, and that's absolutely wonderful. But probably 75% of the optometrists that are out there are still not connected and don't have the ability to send and receive this type of information. And in those cases, we are relying on fax machines, or even worse than that, just calling the office repeatedly to try to get the information from the office, the post-operative information from the office, and recording it, using a human to actually make the calls, a human to record the information, the human to enter the information into our system. And it's extremely expensive in this day and age, where the reimbursements for surgical procedures is being cut almost constantly. So we greatly appreciate the work that y'all are doing, and want you to know that as soon as this is in place, it is going to be implemented very quickly. I'm on the board of a national ophthalmic administrators association, and there are doctors across the country that are waiting for this technology to be put in place so that they can implement it within their offices. A number of doctors that are, a number of practices represented on our board are affiliated with hospital systems that have large hospital-based EHR systems. We won't use any brand names or anything, but those large hospital-based EHR systems are allowing for this transfer of information within their systems. And those doctors are incredible advocates for this ability to send and receive and have access to this data in other offices. They are getting the other doctors excited about it, but the other doctors are still waiting for this technology to truly exist on a national level across all of the different platforms that are out there. So thank you for what you're doing. Just please hurry.
Thank you,
I know we're up on time, but I wanted to chime in real quick. I don't want to cut too much into the break, but hello, I'm Dee Dee Davis. I'm with the Sequoia Project, and I wanted to just connect some dots in case you're not here this afternoon for my presentation that's at 4. But Jim and Dennis and Thomas, you're speaking near and dear to my heart, having been a recovered person in her 30s that had retinal detachment 3 times. I've had cataract surgery. I've run the gamut with the eye. I learned more about eyes in my 30s than I ever thought I would need to know. But I am working as the Sequoia Project in partnership with the American Health and Information Management Association, also known as AHIMA. We just published a data usability implementation guide to amplify all this good standards work on how to make that data more usable as it's sent and transmitted between networks for care quality, for TEFCA as it rolls out, things like that, but actually trying to improve that usability inside the workflow, changing the paradigms for the provider to provider exchange, provider to public health, or even, consumer, me as a patient back to the provider, or, back and forth. So, I'm definitely following this work, and I think there's an opportunity. We are writing a 2.0 guide that's going to come out in 2024, but we're working with the HEMA right now to really get version 1 adopted. And one point I wanted to quickly make was, I know I caught earlier that not all the EHRs are using the right document type We are very, very aware of that. And that's what we're trying to also in parallel for version 1 that was published last year, make it take root. We don't want just an implementation guide to sit on a shelf. We have over 25 organizations who've signed on to be supporters and implementers of this. Big hospital systems like HCA Healthcare. We've had large group network organizations like Civitas, which has a conference going on right now of all the network of networks. So we're working closely with all of these to help make that faster. So just wanted to interject that. And sorry, I ate, 3 or 4 minutes of the break, but thank you for the opportunity.
Thank you, Didi.
I'm happy to answer any questions, but I'll be going more into that work on my presentation at 4 if you're still around.
All right, well, thanks for this, Jim, Dennis, and Didi at the end. Yeah, I'm quite excited. I mean, the guide is out there. You showed it in your presentation. It's the beginnings of some, and actually for the others to know, it's actually using the FHIR structure definition. So it's the same thing as the C-CDA, and it actually inherits from the C-CDA guide. So we're actually, I could show later on, but the templates that we've created are profiles on on physical exam or on results observation or results organizer. So we're showing that it's very easy to create using the structure definition format, and I'll put a link to it in the chat for people to go take a look. So cool. All right, thanks. We are at break. So we have a 15-minute break. Let's cut it down to 10 minutes. I'm sorry that Didi and I stole some of the break, but we'll be back at 2 p.m. Eastern, and Lisa and Catherine will talk to us about the discharge summary status.
Yes, but for those that are not taking off or don't need to run off for a quick break, we can have more vacation photos. So Becca, are you there?
Yeah, I'm here.
Excellent. I was thinking that when we caught a tiny bit of another call or something that you were on. I'm not sure exactly.
Oh, yeah, sorry.
No. It sounded like it was dog related. And I'm a dog person. So I thought I'll come back to the horses because we do have more horse pictures, but I really liked your pictures of, obviously you were camping and you have a lovely dog.
Yeah, we have 2 Great Danes. They look very much alike. So we did North Carolina in the mountains, just really enjoyed that. If you look on the far right picture, you'll see a bear laying there.
That's what I wondered if that's what that was.
Yeah, that's a bear. And it was just very naturey. We had just a very, very relaxing time. And that's me and my best friend, Carol.
Nice. And is that 2 different dogs or 1 dog?
Actually, that's both my dog, the puppy. We also have a full-grown Great Dane as well.
Nice. I thought that they looked lovely. I have labs, but so not as big, but that's nice.
Yeah.
Okay. Gay, are you still on?
I am.
No, Gay. Gay.
Yeah.
Oh, gay. Okay.
Gay, Dave, whatever.
Yeah, exactly. I'm coming back to you, Dave. Don't worry. But this was the most horsey picture, and I thought I just absolutely loved that picture on the left. So, Gay, do you want to talk a little bit about this trip? It sounds like it was lovely.
Sure. Actually, there's 2 trips. So the one on the left is Hawaii.
Oh, yeah,
It's on the Big Island, kind of sort of headed toward the north west end, I guess. It's amazing how much these big ranches they have there, and the grass is like so green and amazing. And it was actually chilly there because of the elevation. And those are 2 Norwegian fjord horses, and they're stocky little things. They're very short, but they're very stocky, and so that's why Bob's feet look like they're almost on the ground. But yeah, it was great fun. And the jet was just a regular cell phone camera. That's real color. No.
Wow, that's amazing.
Playing with it or anything. And then on the right is the Sacramento River Bend, which is about 6 hours south of here, less than that, like 3 or 4 hours from here. And also that was just some amazing scenery. We were kind of right on the edge. You can't tell so much in that photo, but then the river was right down below there. So that was, and that's
beautiful.
I'm the person in red, and that's my Rocky Mountain mare who's pregnant and gonna have a baby in May.
Fun.
And if Dee Dee's still on, I bred her to actually a Pasofino. So should be
So
fun.
Gay, I just want to come stay at your house for a little while. It's Rochelle. I'm inviting myself to come visit you. No,
Careful, she'll bring her
beautiful, though.
ducks. She'll bring her ducks with her. Watch out.
Well, the ducks are gone. I'll bring the horse though.
We had an old retired HL7er from Cerner visit yesterday, so come on.
Oh, awesome.
Nice, nice. Okay, I'll just show this next one, but this is Rebecca that won't be with us until tomorrow. But she sent these in, and I copied and pasted in the little description that she gave, because this is again finishing off the horse theme. But I thought this was super interesting. Had no idea
That's
that
really cool.
people did that.
How it's very rare to have this many horse people in one group. That might say something about the group, because Lisa's daughter, right, does horses too. So
Yeah.
yeah.
Nice. Yeah, well, we'll ask Rebecca to speak about this a little bit tomorrow, because it sounds like it would have been quite the trip. And then let me just see okay. John, are you still with us?
I'm here.
Okay, I love this picture too. That looks like a happy family.
Oh, I guess I should have done something for the summer, but we didn't. We went to the UK in July or late June, early July, but we didn't. I don't have any pictures from that one. It was family visiting, but no, we were at Loon Mountain. I hopefully in the background you can kind of see the mountain we were at the summit for this guy. But with my 9-year-old and soon to be 6-year-old and my wife, we were just having a blast. So and there were no horses, and I don't ride a horse. So for those who aren't horse riders, there's good places for you in CDA world too.
Do you have a dog?
I do have a dog.
Okay, there you go. There's an animal somewhere. Okay, that was my showing of vacation photos. Got to save some unless I get a lot more in, because you can still send them in, and I will add them to the list if anybody's got some pictures that they want to share. I've got some more, but I'm going to save them for the later break. What is our time? Oh, we've got a few minutes yet, so I'm going to go on mute, and then I guess Jean will be back and we'll kick us off again.
So Gay, interesting you'd mentioned it was cold in Hawaii in that picture, because I've been to the Big Island as well. And I remember we took a tour, and it's one of the few places in the entire world that is susceptible to all types of terrain or weather or something. It's got desert, mountains, snow, rain, hurricanes,
Fires.
Yeah, well, fire that's on Maui. I don't think it's on the Big
I think
Island.
they had some Big Island fires too, actually.
Oh, did they? Yeah, I
that's
wish
good.
I would have remembered the stat he told, because it was just fascinating, where everybody thinks Hawaii is just, this tropical, beautiful place. And then you get to the Big Island and it's like, no, it's everything rolled into one. It's so different than the
There's definitely
other islands.
Snow in the mountains when we were there.
Yeah. I think that's where the Volcano National Park is as well. It's on the Big Island. Is that,
Yep.
Yep,
right?
it is.
Okay.
It is. And certainly I've been there a few years ago, I guess, before the big volcano eruption that took out all that eastern part, because we stayed over there. But yes, the weather was amazingly different. And I just remember being in I can't remember the name of it now, where we were, and I perhaps was complaining about the amount of rain we had. And I got told very clearly that if I didn't like the rain, I could always leave.
Yeah, you just go the other side of the island, right?
Yes, exactly. Go anywhere else.
It is amazing how it rains. It rained. We went in December. week before, around Christmas or whatever. And it rained every single day around 11 a.m. for a good 20 to 45 minutes or so. And my kids were young. They're like, I don't know, 9 and 11, 8 and 10, something like that. And so a couple of months later, we're watching Travel Channel and they have something on Hawaii and it's just all beautiful skies. And my daughter was like, no, it rains. It rains every day. They need to show the rain. Every day it rains.
Yeah, it's quite diverse.
Got a couple of people, I think, in the waiting room for the Zoom meeting. If someone can check that.
We do, because I'm checking it right now and I don't see, but I will.
Yeah, we don't have anyone in the waiting room.
Okay, did Eric and Betty get back on the call?
Let's see.
Betty's here. Okay, I see
is,
Betty.
yeah.
Is Eric here?
Eric?
Okay. Eric, yes, is having trouble.
Okay.
Not in our waiting room.
Yeah, Eric Glimpse from.
Yeah, I just got a
Sophia.
message from Eric and he did get in. So he's
Okay.
in.
Perfect.
He should be in the
Okay,
list.
perfect.
Attending.
Awesome. Thanks.
Wow, I don't see him in the list.
I don't either. So maybe
Eric
he'll.
is not on the call.
I think he was in, but he may have dropped off because he's one of the ones that's working desperately to try to be ready for tomorrow's demonstration. So he wanted to be on for the hour and then he was planning on dropping off and working on it after that. So I suspect he dropped off already. He was on though.
And Jim, regarding Gretchen, once you mentioned, I'm like, oh my gosh, what if she's a late registrant and I didn't notice it yet? She never registered, so I don't know if she needs to be here for tomorrow.
Yeah, no, she
go.
needed to be here for today and she just sent me an email. She thought it was 1 o'clock. She's on Central Time. She thought it was 1 o'clock Central Time. So she apologized for that. Yeah. I should add one more thing about John's ski pictures. He was in New Hampshire. I went to undergrad at Norwich University in Vermont, which has one of the largest ski slopes. And when I was a student, which was ages ago, I think John would be interested to hear that the season pass for the Norwich ski slope was $40 a year for the season pass. So I suspect he paid more than that for his day pass.
Just rubbing that in.
Yep.
All right, we're at the top of the hour. So Lisa and Catherine, this is a follow-up to some work you guys did in the last IAT, but it's around discharge summary and the work you've done in the meantime. So I think a lot of us are interested to hear what you have to say.
Awesome. How am I doing? Are my slides coming up?
Yes, they are.
Oh, I thought I put Catherine's name on this. Sorry about that, Catherine. I hope I'm operating from the right deck. Let me just check and see.
And Lisa, you've really done most of the work. All I've done is supply a problem.
Oh, but it's so valuable. All right, let's see why I can't get this to go into show mode. And I click on it, it goes to the wrong screen. About my
there should be a button at the top that lets you switch them. When it goes to the wrong screen, do you see something at the top that says presentation and it'll let you flip your screen?
I see slideshow.
Up higher, like in your, it's
Higher.
part of the Zoom.
Oh, in the Zoom. Remote.
Across the top, it's the
share.
second option. There's 3 options. I think the second one will let you flip it. Not that I do this often or anything.
Which screen do you see now?
The right one. The presentation mode.
Up for me, so let me move this stuff out of the way. Do you see any of my controls, or you only see the slide that says update?
Slide that says
only update.
Yep.
All right. I can reverse my head, so it's backwards for me, but I think it will work. So Catherine and I wanted to give you an update on the project that we have been working on from April, where we have really been doing what I consider continuous improvement with consolidated CDA. And I think that's a theme that you'll see between the project that Dr. Grew and Dennis are working on, and what we're talking about here is squeezing more productivity and better data out of the consolidated CDA templates that we have today. And the commitment from HL7 to support even, moving forward, as Gay and Jean were explaining, with a new IG publisher capability and a new version of consolidated CDA. This is all about a big group of people who believe that we can still do more and better with CDA. And so this project is focused on one of the very important document types in consolidated CDA that Dee Dee's project is trying to get the industry to adopt and to embrace using, the discharge summary. Very valuable type of communication device. And we're looking at some things. The main thing we want to get out of this session is to reinforce the good ideas and the work that got started in April, and really focus on what do we need to do to get adoption or to take root, as to steal that phrase from the Sequoia AHIMA project, to get it to take root so that we can get it into the standards and actually have implementers begin using some of these improvements that should make data and make CDA document exchange better. So we're going to recap just a little bit of that feedback that came in from Texas to fuel this topic that we got started on back in April. And then we'll tell you about what has happened as a result of that group coming forward and bringing this problem, this challenge to us. Talk about some timelines for actually making change, and then discuss what we need as practical steps to sustain this progress. Because this isn't enough. Inventing it here in the IAT doesn't help us bend the needle on getting some improvement to happen. We've got to get the spec changed, and then we've got to get uptake to happen. And that's where we really need more input and more ideas from this group. So Catherine brought us a problem from her state of Texas, and she'll give you a little bit of an update on where that community is going and how they've responded to our initial uptake of their challenge. But folks were really dissatisfied with the information that was in discharge summaries. It didn't have the sections that they needed. It didn't have things presented in an order that was allowing them to understand the information. Wasn't really as concise and lean as it needed to be. And there were just a lot of questions about things that were hard to do. And they brought that problem to us and asked if there's some way that we could address some of these challenges. And so we listened and we worked together to end up putting 4 new JIRA tickets against the consolidated CDA discharge summary. And I think my next slide has them numbered on there. But now we have a whole group of people who will be watching the work that Gay and Brett and Jean are doing to make the next version of consolidated CDA, to make sure that these tickets, which ask for additional sections to be included, or for sections that are just a may or a should, to actually be required, so that the discharge summaries will have the content in them that is really needed for patient safety and for patient care. We worked on a new style sheet. You haven't seen this at all yet. I think if I have time, I'll demonstrate it a little bit, but we'll be working on it more tomorrow in our track. And this is a style sheet where we brought together some of our most creative and capable style sheet makers, and they invented a way for CDA receivers to control the order of the sections in the order that they would like to be able to consistently receive the data. So I think Jim Grew mentioned that the order of the sections is a very important aspect of how the information is allowed to make sense and really be communicative to receivers. And the idea of forcing all content creators to make the documents in one way is one possibility. And I think that the guidance you'll see is coming in stronger for making documents in the right, in a suggested order. But that there's not always perfect agreement around that. And so this idea allows the receivers to have control to make sure that all of the readers of the documents will be able to see it in the same consistent order. And then, as I mentioned earlier, we've started exploring the use of subsections, just like they're going to be using subsections in the physical exam area of the document. We're looking at the possibility of using subsections to better organize the content in procedures and results. There's a lot of material that goes into those large kitchen sink sort of sections, and in order to make the information make more sense and be categorized a little bit better, we're demonstrating breaking those three sections up by using some of what's suggested by USCDI around differentiating clinical versus laboratory versus diagnostic imaging. So that's what we have. That's what we kind of the progress that we made and what we did to respond to those changes. This is the slide that we're hoping the folks that work on the next version of Consolidated CDA will make sure that these tickets get processed and that the next version of Discharge Summary will include a required hospital consultation section. It will require a procedure section with entries required, and it will require a results section with entries required, and then provide a little bit more guidance on how to organize the results and procedure sections so that all of the information isn't just dumped together. The new style sheet is facilitated with a parameter that was added. I'll show you a little bit about how that works. A parameter that allows you to use the link codes of the top level sections in a document and put them in the order that you'd like to see them in. I don't have it working perfectly, and I'm hoping that Matt S. will be in our track tomorrow so we can show him some of the challenge that we've had. Our goal is to have this style sheet working perfectly, a very good sample document that is error-free and demonstrates the use of the style sheet, and then get this style sheet adopted at the working group meeting so that it begins to be available for everybody. This style sheet already exists out in the GitHub repo where the CDA management group organizes the style sheet. It doesn't ship with the base standard. It's not considered a part of CDA, but it's a very useful tool. And this link, if I can up, I will drop that in chat. Susan, you have our slides. Maybe you could do that for me off from the other deck. Drop this GitHub repo link in chat. Appreciate that. Okay, now I'm backwards here, so I got to get my mail. And I wanted to show you this, demonstrate this style sheet for you guys. So how many more minutes do I have, Kath? Do we have about 15 minutes more?
I think so, Lisa.
Okay.
Well, we have a full hour, I think, but keep talking.
Okay. So this is what we'll be digging into a little bit more tomorrow. But I did some background information on a sample document that we created last time. This is a discharge summary document. You can see right here by the link code that tells you what kind of CDA document it is. And this discharge summary has more sections than usual. We included those extra sections that we're asking to have supported in all discharge summaries. And they're in whatever order that I put them in. So you can see, for example, that the problem section is in here first. And I just went through and analyzed all of the sections that were loaded into this document, and I put them in here in the order that Catherine's group from Texas had suggested that they'd like to have them in. But then I noted right here what order the sections were in the document actually. So you can see this number 1 right here. That means that the problem section was in there first. The second section in the document was medications on admission. And the goal is to show how using this new style sheet parameter, which I've populated like this, with the LOINC codes of certain sections, to show that we can in fact render the document in a totally different order. So the 11th section in the physical file is the hospital course section, and this parameter is telling it to be first. This parameter is telling the discharge summary clinical notes to be second, followed by allergies, followed by medications upon admission, like that. And so the idea is that you can apply, and I will show you how you can test this using oxygen. This is just a relatively robust XML processing tool, but it allows you to easily see the contents of CDA documents and work with them. For example, creating transformation scenarios so that I can say, please render this document using a specific style sheet, which I have added right here. That's this new style sheet that was developed last April to respond to those requests. I've set some things up so that it will be exposed in a browser when I do the transformation. And most importantly, I have set up some parameters. So this parameter list right here is the place where the section order parameter that now is available in the style sheet has been populated with those sections that I just showed you from the spreadsheet. Tell the rendering to put the sections out. This one was hospital course. And this one was, I have to peek to remember, the second one was discharge summary clinical notes, and the third was allergies. So just remember those three parts of what we're aiming to do. And if the style sheet is working perfectly, then when I apply it, you can now see that the hospital course section comes first, followed by discharge summary clinical notes. That was what I wanted also. And then the third one was supposed to be allergies, and instead I'm getting these active problems, and I don't know why. And so we have some work to do. Tomorrow we're going to be putting time into really testing and perfecting the style sheet, trying to figure out maybe if this particular example, because it's got nested sections in it or because it has something else going on, that it's tripping up the style sheet. We have a little bit of work to do to prove out the programming that was done in the style sheet to really make it work with that section parameter. But the idea is to release something that will allow consumers to have really easy control, very little different from what we do today, but an easy way of controlling the order themselves.
Lisa, where do you put that parameter in the actual style sheet? Do you know?
Where do you put it? I don't know. I don't know how to answer that. I don't know if Matt S. is on the call. I think if you open the style sheets, you can search on that select dash order and section dash order parameter, and that will take you to the spot in the style sheet where it's defined. But I don't know how you call. I don't know how you call the style sheet when you want to supply a parameter from the outside.
Yeah, so I'm not totally sure what you're asking. Like in your business logic, typically, however you're applying the style sheet to CDA documents, there ought to be some way to pass parameters to it. This is a parameter you can pass in this version. And then for manually messing around with this. Lisa just demonstrated how to do that in Oxygen.
No, yeah, no, that's interesting how to do an auction. I'm kind of like interested in. So what I'd like to do, because this is kind of cool, but nobody uses Oxygen anymore. I'll say it, even though nobody will like it. What I want to do is just build a website. You can do the same thing. So I want to just be able to take the style sheet and get some parameters I can put into a website, and then fiddle the order, and then have it re-render the same XML. So that's why I'm trying to figure out how do I actually pass that parameter into like the style sheet to do the transform. I'm trying to look at the document right now, the style sheet.
So it really does depend on how you are applying the transform. Like if you're making a website to do it, then presumably you'd have some server-side API for handling the transform or whatever. Like it's hard to say exactly how to do it because it really depends on how the API works. But you know, in .NET or Java, or you know, there are a zillion different ways to do it. Yeah, there we go.
Yeah, every implementation is different on how you transform it, how you pass the parameters.
Yeah, exactly.
So it'll be specific to how you're doing it, John.
Yes.
Now, if you want help with that, then you can provide some context. Then Matt, myself, or anybody who knows how to do that can help you out.
Yeah, no. I just put the style sheet link in there. So what is where is like the code associated this in the style sheet section ordering? What's it called?
Oh, it's a
Section
param called
order.
section order.
Section-order, section order, yeah.
I think what I would do is I would search. I would go into.
Okay, doc section numbering, is that it?
No, it's just called section-order. Let me show it again.
And to be clear, this is, like Lisa said, not in the officially released version of the style sheet yet. So you have to make sure to go grab it from the place she pointed to.
Oh, wait, where did she point to for it? Sorry, I missed.
So you have to pick it up off from a branch.
Is it
in the GitHub repo? But it's pretty clearly labeled.
15, yeah, 15
name.
added.
Yep.
Okay. I'm sorry. This is me being slow and
no worries.
I should be interested.
Susan posted the link in
of
chat.
The website, so.
Yeah, it's in an unpublished version.
All right.
And John, I don't know which track you're participating in tomorrow, but we'd love to have you if you want to come, or at least can float through and see what we're doing. We love your innovative ideas.
Yeah. I love that you're doing this ordering. The only thing that I would mention is that what if the order that the CDA receiver is enforcing isn't the order that the data was meant to be viewed at by the sender? And I mean, in most cases, people that are generating the C-CDAs are just generating them out in whatever order it happens to be in. But if they're actually specifying the order so that because it's important and relevant to the receiver, if they override that, then it may not display, as it was intended.
Well, maybe our implementation guides will begin to be bolder about specifying what the rendering intentions are. And I don't want to upstage Catherine's slide, so I'm going to let's hold that thought, and then let's talk about it again in just a minute. Okay. I'm going to go back to timeline. Go back to and again, this is pretty exciting stuff. So that's what we're going to be focusing on tomorrow in our hands-on. But we believe that the next version of Consolidated CDA will ballot in January. Technically, it ballots in this December, which is really not far away. And then it will be published in probably late spring or early summer. So these changes to the Discharge Summary, IG, will be available in specification in a very short amount of time. And the question really becomes, what are we going to do to get implementers ready to start taking advantage of this? Because if people just ignore it or don't follow through, we don't have the right validation and requirements in place to all work together, it could easily be ignored. So we definitely want underscore Joginder for the notes that the ONC understand that we are trying to do continuous improvement for this really important document type, and that we need all the help in every direction that we can find to push us up this improvement curve. And then the style sheet, of course, is just an optional device, but if we get some good ideas flowing, like John's idea, make a website where people could easily experience this without having to use Oxygen or any special tools, the creative juices will start to flow.
So
and
Lisa,
Dennis, I don't have a good I don't have a good answer for, well, what if the creator of the document intends to have their order persisted? We haven't really thought through that yet. I'll put that down as a question to talk about tomorrow.
so Lisa, what's the action item?
The action item would be to have our validation tools get updated rapidly so that discharge summaries that will undergo these changes will have the support of the validation and the scorecard and everything rapidly updated around discharge summary, so that implementers can like benefit from that faster.
Okay.
And then anything else that they can do around publicity, I guess, Joginder, would be the other part. They must have to do some publicizing of the improvements that this work is bringing, and maybe publicity also. Okay, so this is just, really what the IAT is all about. We're so excited about doing continuous improvement and finding ways to connect and make all of this stuff happen. And our practical steps involve getting your organizations to help drive this. It's awesome that we have Dee Dee Davis here from Sequoia, Catherine Lusk driving this in Texas, but we need more organizations and other communities to help become knowledgeable about this and to start moving towards making things better. So if you're an EHR vendor and you can put this on your roadmap right away, go home and tell your group about the changes that are coming and make sure that it's in your roadmap to implement them, that would be super helpful. Catherine, I'm going to turn it over to you to talk about how this continued work is playing out back in Texas.
Well, thank you, Lisa. And I want to reiterate what you're saying to everyone, to the EHR vendors, to please go back to your communities and your development cycles and see what you can do to move this forward. Because a lot of times the community looks to you, particularly the physicians and the hospitals and places like that. They look to you to help them understand what can happen technically. So if you can go forward and tell them, hey, we can relieve some of that pressure, that irritation, that overburden that you're having by allowing you to structure your discharge summaries that you're receiving in a nice, concise way that's lean, that helps you manage your patients. I know that it can only be seen in a positive light, but a lot of times they need you to be that little nudge that they need. All right, so the next slide. So what did we talk to you earlier about? Well, the physicians were overburdened. They're concerned that they're missing information. They have cognitive overload, but even more than cognitive overload and irritation, they're very, very concerned that they are missing information, and it was a patient safety issue. So they really wanted to work on how can we have a technical forcing that requires the information that is needed at a bare minimum to make sure that we care for patients. Now, when Lisa was talking earlier about how that data is structured and displayed, we came up with a structure to display the information that looks very similar to what organizations see within a hospital. A hospital discharge summary, regardless of the hospital, looks and feels very, very similar. There may be unique components based on the individual's care delivery, like, for example, if they're in the hospital For cardiac conditions, there'll be more cardiac components. If they're in there for ophthalmology, there would be more ophthalmology components. And the group recognized this. So it's a bare minimum what they put together for recommendations, but understanding that people might send additional information and that different disciplines might want to see the information in a little bit different way. But also understanding that it's better to have a structure to send out that people can then edit rather than to just send them the entire kitchen sink of a C-CDA. So you can understand why there was a lot of concern. And another thing that the physicians brought up is that these are primary care physicians. And they said that there's a misconception that we only practice in one place. Absolutely not. We often practice in several places. We have our own private practices, and then we have on altruistic side where we work at FQHCs. And the information looks different in those different EHR vendors, but we want a discharge summary C-CDA that is really a transition of care to look and feel the same regardless of the vendor platform. So those are the things that they were talking about. And I know I said these things to you guys before, but it always helps for me to feel better to repeat them. Next slide. So what did we do? One of the things that Lisa and I were talking about is, I just got back from Civitas, and Lisa was there too, and it's regional HAEs, and I flew in from Texas to airport. And I got to thinking about airline pilots, and Lisa and I were talking about it, how everything looks and feels the same. And you know that airline pilots fly on different planes. They don't just fly on one plane. So why is it that they can fly all 200 people across the United States and then we're not concerned and that they feel safe? Well, the cockpit looks and feels the same. Well, a discharge summary is the cockpit that a primary care physician uses to guide a patient's care. Now, there's just one patient at a time, but that patient is incredibly important, particularly if it's you or me. And they also have a checklist. So the format of the discharge summary is the checklist. And that allows them to always look at things to make sure they capture the right information. What is the diagnosis? What were the procedures that were done while they were there? What consultants did they see? What did those consultants find? What are the medications on discharge? All of those different components of a discharge summary are what a flight checklist is. So that allows pilots to fly on different airplanes and in different settings and the people to feel safe. Well, we need that very same thing for our PCPs in our community. We need a discharge summary C-CDA that has a similar look and feel. There's always going to be a little bit of difference based on model and on changes in practices, but a similar look and feel so it's safe. And we need that to be structured in such a way where it calls out procedures, medications, problem list as a checklist so that clinicians who are seeing more and more people, as the gentleman above talked to us about, there's a shortage of ophthalmologists. Well, I would bet those shortage of ophthalmologists, since they're having to see more patients than they used to, it would help them to see information in a structured, consistent, standardized way so that they feel safe, because pretty soon they're going to be coming to you saying that they need things to be structured in the same sort of manner for the same reason that the PCPs in Texas are coming forward. Next slide. So this is the future of discharge summary C-CDA, all with your help. I mean, you guys have just been incredible. There's going to be standardized content that is concise, accurate, and formatted in a consistent manner so that patients are safe. You're creating a patient safety network and decreasing clinician burnout. It's kind of like your little angels in the background that no one knows about, but you're actually going to do more to help healthcare delivery than anyone will ever know. So there's a safe landing of clinical data so that clinicians have that same safety net that pilots do with a checklist and with a standardized format. And of course, I love data usability taking root with the Sequoia project, because they are focusing on that on a much, much broader scale. And they're going to be able to work through this and help us all across the United States. But each and every one of us has to help a little bit, because otherwise it will take that data usability taking root organization years to get there. But if each and every one of us can kind of help carry this torch, it will help Dee Dee and her group get to goal faster. Next.
Did we lose Catherine?
Huh, must have.
Well, I'll kill time while she dials back in for a second. One of the things, we took the progress back to her work group in Texas and did a mini presentation 2 weeks ago. And they were the group that gave us the idea to talk about the possibility of standardizing how certain documents would be rendered, especially in the case of discharge summary, so that folks could all over Texas, that every discharge summary could look the same way regardless of what EHR produced it. And I had a dream right now, if you've ever been to an examples task force, we spend half the time arguing about what data needs to be represented where in the data structures, and then we spend the other half of the time arguing about whether or not we've rendered it correctly in the narrative to go along with what the machine readable entry is actually conveying. And so I could imagine a clinical group cropping up, and they wouldn't have to be experts in CDA to understand how the data gets packed into the machine processable entry. But if we told them what data elements were packed up to be exchanged, they could then sit down and agree amongst themselves, well, if that's the data that's flowing, then this is the best way to render it for clinical consumption, and come up with a standard suggestion for how to handle the rendering part, those XML-like tags that get put into the narrative to expose the information, could actually be standardized by a group of people where that's their specialty, and then the group working together would put out guidance to say, you pack this data into these data structures, and here's how you mark it for rendering up in section.txt. So I think it would be a phenomenal thing if people can agree, and there really is that notion that for patient safety, really clinicians would prefer to see it, at least have the option of seeing it in that standard format. I think it would be a great step forward. Catherine, are you back? Not yet. Okay, so I'll close for her. The Texas Health Authority, I can't remember what the S is for. Texas Health, Dee Dee, do you remember the S? Something Authority is working on within their own community now.
Here she is. Here she is.
Oh, she's back?
Just let her in.
Just about, just let her in.
Okay, good. She should be there.
All right. Welcome back, Catherine.
Hello, everyone. I'm back.
Welcome back. I just killed time until you were here. So we're back on your THSA's action slide, and I couldn't remember what the S
Can you
in
hear me?
THSA stand for.
Yep, we can, Catherine.
Well, hello. Well, I'm glad that you can hear me. So what are we, and I'm so sorry, my computer crashed on me as technology will have happen.
Catherine, can you
So
just
what are we
mention what the
doing
F-
right now? And I'm hoping Lisa has been able to fill you in a little bit about everything that we're up to, as well as Dee Dee, because they're both great partners to us. Well, what we've been doing is we've been encouraging adoption of the Discharge Summary C-CDA, and we've been doing recommendations nationally. I'm going to do a recommendation at a HEMAS conference coming up in October. I've done talks for California, South Carolina, New York, and a couple of other states, encouraging people to go to the front lines and talk to their EHR vendors and their community on using the Discharge Summary C-CDA recommendation. Of course, we're participating with Dee Dee's data usability, taking root initiatives. We're asking stakeholders in Texas to vote favorably on January 2024 on the Giro tickets. Lisa came and gave us a discussion on it and what the ticket numbers were so that we could ask our community to vote for them. And if you're going to be there, I'm going to ask you to vote for them too. We're also looking at the different subsections. We loved Lisa's idea to reorganize the procedure and results section, assessment and plan, so that they can be more organized and lean and concise. We also agreed with you guys' discussion that initially that coming up with the format that information is displayed when it's received, that we wanted to give some people a little bit of flexibility there. And that was always our point, is to give people a little flexibility, but to give them a standard to start with where they could add to it, but not really take away from it. Next slide. All right, so this is a challenge to you all because you've actually challenged me quite a bit. Is there the potential for HL7 to engage clinicians and other stakeholders and work groups on the content and display of clinical information? That would be beautiful, so that you wouldn't have to wait on people like THSA to come to you and say that this is a wrinkle and something that needs to be solved. Of those 13 different document types and those 70 some odd templates with C-CDA, each and every one of them are unique. And having clinicians come and talk to you about what's the best way to display that clinical information and what should be required instead of optional. That would be helpful to you. And I don't think it would have to be big groups, but maybe you could rely on the Sequoia project, the usability work group, as a sounding board or subject matter experts to come and give you feedback so that you could work on improving those things faster and be more agile. Because I heard Lisa say that you're really working as an organization on agility. And we love the idea of the C-CDA validator so that people could look at the data and see how it was being displayed in their own organizations. Because I'm going to be truthful to you, when we went back and talking to our community about the use of style sheets, a lot of the times their vendors didn't understand what style sheets meant. And so our community has had a difficult time, particularly with some of the ambulatory vendors, and talking to them about what a style sheet is and how it displays the clinical data in an organized manner. So if you guys had a C-CDA validator tool that was easy for people to use, then I could then give that to my community. And when the questions came up with their EHR vendor, they could point them to this so that they would understand what the ask was. So that's my challenge to you. Any questions?
So Catherine, as far as the C-CDA validator goes, like I'm sure you've seen the ONC's validator, which, you know, people I think tend to sort of use as the gold standard for C-CDA validation because as far as USCDI and all the regulatory requirements go, it's what the government tends to use. So I'm sort of wondering about your question there, what it is that you're looking for a validator to do that can't be done today by the ONC's validator or by the HL7 release C-CDA schematron?
I think that validator and I could be misunderstanding, but I think that validator tells the content that's available. That doesn't show the style sheet on how it can be displayed. It's kind of going back to what Lisa was showing earlier, the different display methodologies.
Mm-hmm. Yeah, and
Right.
it definitely
And
doesn't handle display.
author could be populated, but you don't see it exposed in section.text. The effective time could be populated, but you don't see it exposed in the section.text.
I see.
Mm-hmm.
Okay.
Does that make sense, Matt? Because
yeah, I'm with you now.
Yeah, because we had we sent out information on the C-CDA validator to our community to make sure that our community was sending the appropriate data. And we said, okay, look at this, run it through, making sure that you're being a good partner. But there is no way for them to say, how does the data look? A style sheet is coming in.
No, I'm not aware of any validator either that actually does anything about the display of the data itself.
Mm-hmm.
So yeah, that is kind of interesting.
And you can see then when I ask our community to go out and talk to their EHR vendor about use of a style sheet and to display the received C-CDA data, either the vendors don't know what they're talking about and I'm sure my team is the clinicians in Texas are saying style sheet because they won't know any other word to use. So they need something to point people to their vendors to say, here's what HL7 does to make sure that their data is displayed this way, or here's a tool to do this. And is there a different word that people use than style sheet?
I mean, that's the one that I think everybody here at least uses by far the most often.
Mm-hmm. So those are my challenges to you guys.
And even, Matt, if we started out with a human checklist before you tried to automate it into a validation tool, but a human checklist that said, if your document is passing validation, then you should have these X fields populated in your problem entry. And the way that those should be presented should be the following fields, even if you give a example of a table structure with certain column headings and they're in a certain order, that can make a difference for how quickly a doctor can assimilate information. If they're having to figure out every time I look at it, sometimes I see 3 columns, sometimes I see 5, the labels are different, what is what? And if we had some basic guidance on how to render on an entry by entry basis, if the required fields are present, then as a minimum you'd have this rendered view.
Yeah, that makes sense to have
entry.
a human checklist of some sort. I'm not aware of, Matt asked, maybe of the the possibility of of a technical support of that. But I'm also wondering, it seems like vendors that have implemented CDA should certainly know about style sheets and the relationship between style sheets and C-CDA or CDA. I kind of wonder if the right folks are being spoken to from the vendors.
And Gay, that is probably part of the issue, but when you think about physician offices and they're the community that's caring for them, there's primary care physicians, they will have a vendor, and the technical support from that vendor community are the people that they can talk to.
Right. So you're talking to first line people that really may not. Yeah.
And so that's creating a wrinkle with getting adoption in Texas. Now, larger organizations like Epic and Cerner and they have people inside that will actually know, but these smaller organizations, and they'll be having the frontline EHR support team, is really more of a ticketing and it's difficult for them to get past that.
Right, right.
So I need
Catherine, there is one other thing I should mention also that you just made me think of. Like everybody here at the IAT tends to use the word style sheet. But if you're talking to other vendors and they're just like wondering what that is, if you use the term XSL transform instead, that might get you a little bit further.
What was that, Matt?
XSL, like X-ray Sierra Lima transform.
All right.
Yeah, so
I'll type it in chat, yeah.
we understand what you're going through there for sure, and it is hard to get to the developer and the focus person that is actually doing the coding to put the style sheets in the application. It's as simple as having also, if you are receiving direct messages, having the direct hiss help include that style sheet or know that you're sending the right style sheet to go with the document that you're passing through. So definitely hard to get to the people you need for specialty EHRs or even smaller EHR systems. It is a challenge, but I think what was called out the XSL transformation, or just speaking frankly about the way your document's viewing or what you're able to see in the machine readable part, the human readable part of the data and not just the machine readable part.
Right, and saying something like, and using the ONC validator and you can say, I know that this data is there and your system is not showing it to me. And even something like that, rather than saying, oh, are you using the style sheet? Just because then that's like, whoa, we're not showing data that's present. That's a patient safety issue. And bring up a patient safety issue and that.
But having
some EHRs don't implement the style sheets, and they're doing something different, like a movable view of the data where you can organize that data. And they've done something in code, and they're not necessarily using the style sheet for the front end part, but they need to be providing a style sheet when they're providing their data if they're not using something standard. So the XML should always come with a style sheet if it doesn't work with a standard style sheet.
I think that you all, through your work, can help move that forward. Because honestly, I'm afraid if I say XSL transform, that those frontline ticket answers in those settings are going to be just
agree. And that's why I'm saying, that you could advise your people to say, look, can say the government validator tells me my data is in there and you're not showing me my patient data.
And that, Gay, is probably, we do tell them to say, this is the way that and honestly, they will say, and I'm going to use Epic because they will say, Epic is not sending this data. And then I said, no, I know Epic is sending this data because they have shown me they're sending this data. You're not showing this data to the PCP. And so let's talk about how are you, and so we are getting to that point, Gabe, and then once we get past that, it's how do you display the data in a consistent way?
Yeah, that makes sense. Thank you, Catherine. Yeah, that I agree with you. Yeah, it's like, but there's a bunch of different things going on there because maybe they put, like for eye care, Epic will put it in narrative, but they don't put it in structured, and everyone's starting to do that. There's a bunch of different things going on there.
It is.
Absolutely. I think that the biggest thing, and what Gay is pointing out, is that there's some information being blocked here, right? And we see it in this format. And if you're seeing it in the XML, you're either seeing it as human readable or machine readable, or both. And a lot of times they don't align. They're supposed to, but a lot of times you'll have information in your machine readable that's not in the human readable. If it's not in your human readable, it's not going to render to your style sheet properly. So those are things to think about as you are going to the front line and asking that and putting in a ticket. You need to use words such as machine readable, human readable, and leave style sheet out of it. You can leave XSL transformation out as well.
It's I can't see it in the user interface, or I can't see it in the PDF, but we can see it in the XML. And that should help that front end get the right information back to their team to troubleshoot the problem.
All right, I'm going to call time. You guys, I let you go because it was a good conversation, but we're in the break already. We've got 5 minutes before that, or 7 minutes before the next topic. Thank you, Lisa and Catherine. That was really good. Good to see the information that's going on and a good discussion. So.
Well, and thank you for having me, and I apologize for my computer crashing in the middle of my conversation, but I'm sure Lisa carried on without me.
She tried her best, but it wasn't.
Oh, good. Thank you.
All right. Thank
so
you,
yeah, we'll
guys.
give just a 5-minute break, top of the hour, and then Gay's going to talk to us about USCDI, and then Linda's going to talk to us on a pair track status update. So 5 minutes to get some water, bio break. We'll be back at the top of the hour.
Great.
Susan, are you still on the line? Hello, hello?
I can hear you, Lisa. I see Susan, but she is on mute. No problem.
By the way, Lisa, I just figured out what was up with that issue we were talking about like allergies and things not showing up in the style sheet when you use section reordering.
Awesome.
So I have, like I told you, the process right now on GitHub is a little convoluted because we have the HL7 branch, and then I have my fork of the HL7 branch where I have some fixes on top of the fixes. So what we ultimately want to do is like take my stuff, smush it on top of the HL7 branch, and then smush the HL7 branch on top of the style sheet, and it'll just become the real thing. But obviously that hasn't all happened yet. So right now, if you use the link I just sent you, that's got like my copy of the style sheet, that should be the most up to date.
Okay, and
so
I thought I would
also
download that, and then I wanted to ask Susan about, I wanted to post some things so that tomorrow when we get started on it, the group will have the same discharge summary document and the latest, greatest style sheet.
Mm-hmm.
So other people could be practicing the transform and trying a few different things.
Yep. So in any case, I just like applied the fix to that GitHub link I sent you. So if you re-download the style sheet from there, it looks like everything should be working now.
Okay, super. Thanks so much for doing that. That was a big part. There's a lot of schematron errors I have to work on in the document.
Yeah, I saw the schematron errors, and it looks like those are mostly just actual problems with the document.
Yeah, addresses, and I think it'll be straightforward to just kind of hammer through those. If I have some time tonight, I'll pick through some of those problems, so that'll be a little bit cleaner. And then I'd like to try and focus the conversation tomorrow on what's the real impact of making a document that takes, like, say, for example, if we took the results section and expected that implementers could distinguish the lab results from diagnostic testing from everything
That's in our
else.
next section.
Okay, good. So we're wondering whether or not that's going to be possible. Good.
Yeah. I think Gay's going to touch on it just a little bit through that process, maybe. I keep putting a lot of pressure on Gay, but that is one of the things.
I am, and there's not a great. answer, to be
That's not a
honest,
great
but-
answer yet, right? But we can get
answer, to be
That's not a
honest,
great
but-
answer yet, right? But we can get one, and Lisa would
Well,
love to
no, I
work
mean,
with
it's
you.
definitely possible
make it-
to do it. It's
Yeah,
just,
yeah.
you know, requires work, so. Terminology work, you know,
Yeah.
terminology.
I'm not against work if we can figure out how to do it, but I'm also concerned about this expectation. If this is considered a solution and we start to do things like that, IHE specifications have always used subsections, and we've stayed away from it in HL7 except for in the physical exam area, which really wasn't exercised much. So if we start doing it, I'm just wondering what impact, like you go around the room, ask EPIC, ask ECW, ask whatever other EHRs are present, will they be able to do it, and would they be able to consume the data if it was subsectioned up?
Yeah, if you, like, does the discharge summary that you send out, oh, it does have example subsections, awesome. So I believe that we support rendering those in our own style sheet that we tend to use. Yeah, so I just ran the discharge summary sent through EPIC style sheet to see what it would look like. And we can support that. I mean, then as far as the discrete data goes, actually, how do we do the discrete data in these sections? That's an interesting question too. Because there's a question of like, do you have discrete data in each subsection, or do you have it all in the parent section?
Yeah, we put the discrete data in each subsection, and I mean, another option would be to just subsection the narrative and keep all of the entries for the problem section, for the procedure section, for example, all at the level of the high level section, and just do the narrative sorted out for the humans. But
yeah, because I don't think right now we would be able to discretely parse data out of subsections in the procedure section. Like I haven't actually tried doing it or anything, but my guess is that that would work. Like I feel like it's much easier to just make your style sheet support rendering subsections in there than to have your discrete parsing logic figure out. Well, I guess I can think of ways that you could have your discrete parsing logic just sort of be able to handle it too, but I don't think ours does right now.
You're going to say, oh, this is a clinical lab, and you're going to do whatever you do with labs, and this is a radiology report, and you're going to do do whatever you do with radiology findings. So I think that was a thought.
We've only given Gay 30 minutes to answer everyone's questions in USCDI.
Okay, we're shutting up.
All right, yeah.
Well, that was Gay with horses and dogs.
Yeah, all my dead ones.
No. Well, that's a downer.
Oh, no.
Wow, that's a ray of sunshine right there.
That's sad.
But you know, whatever. They had good lives, and I got new ones.
Exactly. Oh man.
Yeah, I was hoping my other one would show up, but maybe when I stop sharing, the other one, the live one, will show up. So I think to some extent, anyways, we're going to run through this. There were some questions that Rochelle forwarded to me that just were wondering about where the guidance was around dates around diagnosis, and then the discussion we were sort of kind of starting to get into, which was clinical tests and diagnostic imaging, how to differentiate. And so the first issue was they were unable to find the guidance around data diagnosis and data resolution, and how known issues such as onset data is not the same as data diagnosis, abatement data is not necessarily the same as data resolution, and there is guidance. So I think it was just a little bit, so this kind of, someone took a sneak peek at the slides and said, oops, so yeah, I didn't find that. But now I see it. So I think this will serve useful just to kind of make sure folks understand how to navigate current PDF before they have to learn how to navigate the structure definition application. So date of diagnosis is present as a template in the latest companion guide or 4.1. And in that, we actually do recognize that date of diagnosis is usually not the same as the date of the condition onset. And a patient may have a condition sometime before it's formally diagnosed. And this is a template that is recommended to sit inside the problem observation. That literally is the LOINC code that says earliest date of diagnosis, and then some constraints around time. And again, it sits inside the problem. It should sit inside the problem observation template. This is in Appendix A of the companion guide, and in the companion guide is got 3 sections to 3 documents to it currently, 3 PDFs. One is what we call the main guide, and which is basically the textual guidance, and then Appendix A, Appendix A and Appendix B are templates, contain templates, and Appendix A is the one that contains the USCDI templates and guidance. So, and there's also an example. This link, by the way, this is the link is to the Navigator version, and that's why I said also page 102 of the Appendix A. And there's an example here, and it does say, should sit inside the problem observation. Here's the XML representation example. And then there is guidance in the main guide as well, which is the guide that the PDF that has the general textual guidance. So in table 75, it's important to recognize that our guidance for the USCDI data elements, our additional guidance, is primarily in tables. And so in the first column, we have the USCDI definition of the data element. This is the template column that says, that this is the data represented with Date of Diagnosis Act, and then the specific item that captures the meaningful information, which is the effective time at value, which will capture the effective time. And when you see there are also additional sections below the table that if we felt like it wasn't conveyed well enough in table format, why additional guidance was added. So it's either hearing some background noise.
I'll take care of it.
Okay. So that this no additional guidance means no more guidance seemed to be needed than what is in the USCDI table or in the template. So that's just a little orientation there. Again, the date of diagnosis sits inside problem observation, and you can see that when you look at the template, and you can see that this table references either what the template in view is contained in, and in this case it says none because it's in the companion guide, even though problem observation is in a problem section, but it's just the way the tooling works. Anyway, you can also see the contained templates, and here you see Date of Diagnosis Act is contained inside problem observation. Data resolution. This again this is in the problem observation, and we have asserted for some time that the onset date and resolution date are represented in C-CDA, CDA actually, with effective time lows and highs. And there's information in the templates that state that. This is just a screenshot of the template. And then also, if the problem is known to be resolved, but the date of resolution is not known, then the high element shall be present. And null flavor is set to unknown. So that basically says, I don't know whether the patient still has the problem or not. Date of resolution is again, it is a USCDI data element, and the definition of the USCDI data element is here. We state that it's in the problem observation and it's represented with effective time high. And again, just as a little reminder there.
Gay, can you go back one slide? I think what you said is that if you don't know if it's resolved, it looks to me like the words are saying if you do know that the problem is resolved, but you don't know when, that's when you use effective time high with a null flavor of UNK. So by populating something in effective time high, it means it is resolved,
Right,
but you
right.
you use UNK simply to say it's resolved, but I don't know when it actually,
Right,
you know,
right,
when exactly that stopped being a problem, but it's
Yep.
not a problem anymore.
That's exactly right.
Okay, thanks.
I think I didn't quite say it that eloquently. And so yeah, so C-CDA, this is just some notes here. Like I mentioned, has always considered problem observation effective time high to be resolution or the end time of the problem. And we don't really have a separately modeled softer concept of abatement or subsiding, which is in the USCDI data element, and fire has an abatement date. And an abatement is sort of, is more like, you know, it could be done or it could be just better than it was before. So it's a little bit more of a fuzzy thing. But, you know, I noticed yesterday that we, you know, even though we have defined effective time high as pretty much the resolution, we also have decided that is effective for saying that it fills the abatement definition as well. But I think in both cases, you need to be sure to consider both in CDA, the problem status, and in fire condition dot status. Those two things together to really determine whether it's just, you know, has gone into remission or is resolved. Date of onset is not yet a USCDI data element, and so there is not additional information in the main guide. However, you know, we have, as I mentioned before, we've considered effective time low as the onset, as opposed to the date of diagnosis, which, as we all know, can be 2 different times. Any questions about those or navigation of the 2 guides, the 2 parts of the companion guide?
I have a question, as Rochelle, regarding the date itself. As far as, is that kind of standard throughout C-CDA to say the high if it's UNK, or is it very specific data elements that you're allowed to use UNK for the date high?
Unless it explicitly says you can't use null flavor, then yeah, I mean, you can generally drop a null flavor in there, which says, well, there is a high, it has ended in the case of a date range. I just don't know when it ended. And that would be true of many things.
Oh,
And can
yeah,
you put that
Rochelle,
in
you were
the
asking
low
whether that
as
could be
not
used in
knowing?
other places. Is that what you're
Yes,
asking? Yes,
other
you
places,
can.
exactly.
Yep.
Okay, and for low as well, or is it usually
You
only
would
with
say, I
the
know
high?
this started, I know that this, I know it became clinically active, I just don't know when, right? In this case,
Yeah,
that's
so
what effective time would mean.
a bunch of our EHRs come to us with, well, I just know it happened in August of 2023. So what do they do in that? What's the advice in that aspect when you don't know?
Use a date. Use
start?
a date that's only as precise as what they know. You know,
Right.
date time information can be populated just at the year, and a month. You don't have to
So just drop
fill it
it
all the
off.
way out
Okay.
to
Okay.
time.
Okay.
Yeah.
And you don't have to use it. You don't have to have a day of the month. You can just have a month and
Correct.
a year. Okay.
You could even
got
have
it.
just a year.
Right.
Okay. All right.
I think there are a few cases where it's more precise than that, but you know, throughout CDA, but in most cases, it's, you know, you only should be as specific as you know.
So,
And that's much better than putting NI, which, you know, unfortunately, also, as you know, Dee Dee probably knows, a
No
lot of
information.
times they
Right.
just null out the times.
So there must be like an intermediary between that, right? As in, if there's a rule that says you at least have to have a date down to the month, day, and year, you stick to that rule versus the flexibility that Lisa just said. Is that correct?
It would be in the constraints if you needed to have it, because we'd have an invariant that would say you need to give us down to the month or down to the day. So if it doesn't say that, then you get the full capability of the data type.
That's
I don't know if
interesting to have just a
databases
year.
allow you to, sorry, Matt, go ahead.
No, I think we kind of along the same line. While it seems like just a year may be valid, do y'all feel like that's still okay? It like let's say I don't know the month and the day, but I do know the year, and so I put that versus putting null flavor unknown or NI.
Yeah.
The
Well,
year.
we're-
So
Yeah.
this happened
Go ahead.
Because you know something.
Yeah, this happened when I was 4, so you'll put that. Well, I won't tell you what year that is, but
Yeah.
I just don't think that databases support
Yeah.
that, so we have to look at
Yeah.
that, because that's tricky.
Yeah. Exactly.
very
Like Rachel said, most of them, you'll put like a full date or a date and time, but usually you wouldn't specify just a year.
Yeah, so that's intense. I mean, because it sounds viable and possible, but I just never seen it. So I'm
yeah,
curious how we'll.
wild, right? Like you'll see, so 2004-0101. Right?
Uh-huh.
So one of those January 1st, you're like, did it really happen January 1st, or is that just because
Okay.
Yeah.
you have to do a
Okay.
In iCare, if you think about it in iCare, like a complaint, like if you're
Mhm.
following the coding rules and you're documenting a patient complaint, they might do exactly that. We did implement the ability through textual fields for the patient to say, yeah, it happened in this year, but I don't know when, and then you could translate that into a C-CDA, but in general, date time fields don't translate.
What about
Okay.
transmission to fire, like of that date? I don't know that we can do
Fire
that in
allows that
fire,
as
can we?
well.
It does? Okay.
Time doesn't require. I mean, there's
Yeah.
different date time data types, and some like instant does require full out, but the date you can have just the year or year month or year month day.
It
Yeah.
seems, it seems like there needs to be like a qualifier on that. I'll give you a clinical example. Almost any eye care provider can tell you about a diabetic patient that comes in, claims they're not diabetic, but they have diabetic retinopathy. Well, almost nobody develops diabetic retinopathy until they've been diabetic for over 10 years. So that person that comes in hasn't seen a physician, you talk to them, they've had symptoms for a long time. That's not a new diagnosis. And if their date of diagnosis gets recorded on the date they came in, because when did it start? You have no idea, but there's a high probability they've had it for years and years and years undiagnosed. It seems like a qualifier.
Diagnosis is, I mean, it's really, that's a meta field, right? Date of diagnosis is when did the first person say you were diabetic, right? So it would be today. You would say, well, when did it start? Well, it had to have been in the past, but I don't. So you could put a low and put, UNK to say it happened, but I don't know when it happened. And it would be potentially different from the date of diagnosis.
But almost like a qualifier that says, hey, pretty sure this has been around for a long time, because that data diagnosis is used for a lot of like risk factor calculations and how often do you do certain tests and stuff. So if all they do is take a quick look at that data diagnosis, they might think it's a new diagnosis on a patient that was actually just developed diabetes, which is clinically going to be handled completely different than a patient that's had diabetes for 10 years.
Right.
I know that all makes sense. I mean, John, go ahead.
Example though of the difference between problem observation effective time low and the date of onset effective time information. In the example that Jim's cooking up, the diagnosis effective time low is today. Today is the first day that anyone has ever diagnosed that I have diabetes. But because it's a guy who's looking at my eyes who says, because of what I'm seeing, there's no way this patient hasn't had diabetes for 10 years.
Yeah.
The date of onset would be that effective time low, and date of onset would be the 10 years ago.
Yeah.
Right.
Well, although it's when we say that,
I mean, what you're saying, if people are using the date of diagnosis as more than what it is, which is purely, this is when I recorded this diagnosis. I recorded that this person, I believe this person had diabetes on this day. That's it. And it doesn't mean that's when they had diabetes.
Yeah.
They
It's when that provider recorded it, and it could be that it was recorded before, but you don't have those details and you don't have anything to substantiate it.
Exactly. Yeah.
And then, we do have a notes, a note template that you could contain and to add that, sort of fuzzy information.
I think the flexibility you guys have in the objects are correct. It's just, a lot of people are just saying, well, we wouldn't do it that way, but I guess it's good to have the flexibility.
And yeah, you could put a confidential note to say patient says they don't have diabetes, but they're lying.
But you can seriously though, for data diagnosis.
This is where we go back to the communications, like, when like the Node 2 network and some of the stuff Jim talked about, like a lot of referrals that come to an optometrist or an ophthalmologist, they're not sending the C-CDA. They're not providing them with any detail, or if they do, maybe it's fax or paper, and it's not getting entered.
Right.
But they have to have gotten something.
So I have one more question. It's my last question. We talked about the year and like the date parts being acceptable, but somebody said that, if you knew it was in 2023, but you didn't know the month and the day, you'd put 2023, but in your system, you might do something like January 1st, 2023. Is that still acceptable?
No.
Well,
No.
so no and yes, right? Like, so no, it shouldn't be, because how do you distinguish between this actually happened on January 1st, 2023.
Exactly.
Versus all I know is it was in 2023 at some point, right? But I mean, there are conventions, right? Like, so that's the problem, right? Is, that one in 12/31, right? Like 12, high of 12/31/2023, right? To say, well, this occurred sometime it ended sometime in 2023. I don't know when. Right.
Yes.
And you see both conventions, and it's data that's there in the wild, and it does muck about with our systems, right? When you want to do a find me, how do I do fines when, something that was reported in January, and all of these, we have
all quality measures, all of our quality measures.
Exactly.
When they're deduplicating data, when they're one that says 1/1/23 and one says 12/31/23, which one is right, and all of that. Yes. By the way, I work with clinicians and physicians all the time, and a lot of them admit to me that when those fields are required in their electronic system platform, they a lot of times do default to that, because it's like, well, it was sometime in 2023, so they just stick a date in because it requires a date for them to enter.
Yeah, again, that's if your EHR is forcing you to put in a full date, right? What do you do, right? So but we're saying underlying standard, the data underlying standard does allow you to just put year month, and year month date.
That's good to know. Okay.
And then just making up the date also has ramifications against insurance companies as well. So those things have to be really considered.
Yeah, that's what I was going to say, like to have like an update date. We have that with optometrists and that where they have the data diagnosis or the onset potentially. And then as they're, working the plan over the course of several years, they update the chart multiple times. We have no history of all those updates unless you go back and go to the encounters. And I thought maybe an update date would be useful, but anyway. Cool. Thank you.
All right, back to Gabe.
Right. So this is a really good question. The issue that was stated is that in US Core, there are two different profiles. There's the clinical and diagnostic test use US Core observation clinical result profile, and then the laboratory test one is differentiated out, which it has been for a while. But then there was some work in 6.1 with respect to clinical and diagnostic tests using the observation clinical result profile. And the statement was, with no apparent way to make this distinction in C-CDA, we're uncertain how to adequately map these test results from C-CDA to FHIR, other than adding codes to the terminology server and doing a lookup per LOINC for each result that will work for their implementation. But still, it seems like this is an issue for other mappings that people are doing. And yes, that's true. Really, in both directions, terminology is going to have to be looked at to understand. Either if you're a developer and you're wondering which profile to use for the thing that was done, and if it's a lab, then you're going to use this, and if it's and everything else, you're going to use this. And they also would have to look and see, well, is it a type? If it's a class type 1, then they know it's a lab, which is fairly straightforward, but still it has to be done. And so in the same case of representing in determining like what a C-CDA result, whether it should go into the clinical result profile or the lab result, same thing is going to have to be done. And so the other interesting thing is that the lab results profile is derived from or based on the clinical result profile. And you can, we don't really have time, but when you look at these, you can see that the lab is derived from this particular one, and is all the currently the observation clinical test result is all of LOINC, which it's not such a great thing either, because all of those things are not results. There's many types of codes in LOINC besides resultable type of codes, but that's we always talk about is the bang worth the buck to make very large value sets that are appropriate. And maybe I think kind of there are, and there has been work that's done, but you'd have to determine since results and clinical tests are pretty broad, and I don't think there's anything simple you can do within LOINC to derive that. But it has been some work like that. LOINC results are class type 1. I think radiology types are class type 4. But there is what has been work done by RSNA, like if you really wanted to know what should be diagnostic imaging versus lab. And I'll actually put this in the chat.
That if can I ask a question, Gay?
Sure.
On that, so is there any reason why, like for us, like LOINC just doesn't really suffice for clinical results in eye care? So then, does it have to be LOINC? Can it not be SNOMED? And it's interesting you said that the lab observation profile was created from the clinical. So in eye care, you don't send it out to a lab. It's based on observation methods, but it's what the doctor's seeing through a microscope or through equipment. And LOINC doesn't always really fit that profile.
So when you were talking about that earlier, I was wondering, are you looking for the answers, if you will, or the question, like the test that was done? Typically, in both of these profiles in the US, we use LOINC codes at kind of what the question is or what the test is, and then your result is in the value, which can be numeric, and often if it's encoded, we recommend that it's SNOMED. So yeah, I'm not sure. I haven't looked at LOINC to see, and certainly wouldn't have the expertise. But so you're saying there that the LOINC is deficient in
clinical findings. Yeah. I mean, pathology and just in eye care, the way that they do the results, it just SNOMED fits so much more.
Though, Dennis, the code is what test was done. So that I think LOINC had.
No,
it doesn't.
I review all of, when we do that part of it.
Then you've got a problem with US core as well, because it's mandated LOINC for the code in observation. So like in this, so far the stuff you've given me, we've had the codes have been fine because they've all been LOINC codes. The results have been SNOMED.
Right.
Right.
So a way to get around that, or not get around it, but It's well, it's extensible actually.
Yeah.
So you could use other codes or local codes. I mean, although it'd be using local is not great for interoperability, right? But you could use other codes. The extensible definition in FHIR is if there is not a concept in the value set that is covered, then you may use another code.
Didn't they also request link codes though?
That was my next statement.
Oh, sorry.
That's okay. And the other thing, and probably the most important and most valuable thing for you to do, is to request link codes to cover the ones that are missing, because that's
Yeah,
that's going to be the best way.
That's a good point. So yeah, we didn't use link codes, John. We only used them for the findings of the narrative divide. Everything else below on the organizer and the results observations are all SNOMED. The problem with that is that there's tens of thousands of codes that just don't exist in LOINC. I mean, so why would we want to make LOINC be a copy of SNOMED? And I guess there's pros and cons to that, but LOINC is just not going to fit the bill from a clinical point of view for the eye.
I'm just wanting to verify that. So here, this is where the stated test would be, right? And then the value should be, the resulted value is recommended to be SNOMED in, if it's not a measure, if it's not a quantity.
Like a PQ, yeah.
Right.
Yeah, we couldn't even do it for the code. I guess that's what I'm saying. The code, it was not possible to put LOINC codes for all the codes.
Yeah, I spend a lot of time, this is Jim, looking for those, and we always review LOINC first. And so we look at LOINC and SNOMED. Once you get down into a lot of the common tests that are done or observations, there's no LOINC code for either level, the result or the test itself, in the vast majority of them.
Okay,
but we tried to keep to that spirit, which is what I was saying, John, before with the extensible. It kind of, if you look at the actual implementation guide, it does say LOINC should be the primary, but you could use others. Yeah. So we picked SNOMED as being the most appropriate.
And are they SNOMED procedure codes?
No, not always.
No.
If there's a code that I can find for LOINC from a procedure code point of view, I'll do that. But these
no. I mean, for so what kind of codes in SNOMED, from what hierarchy are you successful?
Oh, all sorts of things: findings, objects, procedures. It would be all a bunch of different categories. Yeah.
Sometimes the LOINC code combines combinations that don't make any sense, or make it really complicated to do it using the LOINC code, whereas the SNOMED code fits exactly what you're doing.
Yeah, I don't want to take up all the time here, but maybe this is a discussion we can take offline or something. And
yeah, because something doesn't quite sound right to me. I mean, I totally hear you that the LOINC codes, are likely deficient, but using, codes from SNOMED from all over whatever hierarchy may not be the appropriate thing to do. So, depending on where it fits. So I'd be happy to help, and I'm sure Jean can loop me in, if you like.
Yeah, if you go look at that iCare guide that I posted earlier, Gay, you'll see the current for refraction and visual acuity, the observation.code that we're using. So yeah, if you go down refraction observation codes and visual acuity observation codes.
Ooh, the first IG in the new publishing method.
Isn't that nice?
Yeah. So the problem with LOINC, and I do agree with you, Gay, that we could add a bunch of codes, but I think the number of codes we're going to add is going to get crazy. They will put power of sphere in LOINC, but they combine it with a bunch of other attributes saying it has to be a phoropter and it has to be this, which is not always the case. So if they would put the base code without putting all the attributes predefined in the single code, what they've done is represented the power sphere and a bunch of other things in one code, whereas really we need 20 codes to represent, what we want in LOINC.
Yeah,
and so, And so, I mean, following the IG, it does say that you can use other codes, and
Sure.
obviously LOINC was our preference, but it just didn't work out so well.
My computer's
So,
supposed to go
so
down.
I feel like I need to go back to like even prior to like what codes to use. To what type of test is it, is where I'm still stuck. Like
Right, so
in
here's-
V2 of HL7, okay, so you have class types, okay.
Yeah, well,
So-
class type 1 is labs, and that's
Okay.
what's constrained in US Core. So you would,
Okay.
to say, okay, if I'm going to put it into the lab,
Got it.
Or vice versa. But that's the easy part. The
Okay.
hard part is the everything else.
Yeah.
Everything else. So in HL7 V2, there's a field, right, that dictates what exactly type of test is being done. We're just losing that in C-CDA completely. You can find, because you can, in your OBR segment, it tells you whether it's rad, lab, cardiology. It gives you all the different tests, microbiology. There's codes used specifically to identify the type of test. So the EHR systems may or may not have that stored. It might just be being added in by where they're sending the order to and who's resulting, but you do have an identifier. Is there no place to put that identifier in the C-CDA itself?
So yeah, I'm woefully inadequate in V2. But somebody will have had to have still done the terminology work if LOINC is being used to determine what that ID in that
Well,
OBX
I don't
field
think it is. I don't think it is, because some, like Quest and LabCorp and all the lab systems, they don't all use, for years, they didn't all use LOINC. They've recently all moved to that, but for a long time, they didn't use LOINC codes for their results. And so they did have to indicate what it was. And I don't think I guess their own mappings had it, possibly.
Can you list the OBR field in chat? I think it's very interesting because we're trying to bring you guys more closer to us. And this is an kind of data that.
Lisa, you're breaking up.
Yeah.
When OBR is the panel code, right? Well,
Yeah, so it's going to be it's the one below that. It's
OBX,
the
OBX.
OBX,
the
yeah, the OBX segment, yes.
OBX3 for the LOINC code, but they used to send their compendium local until.
But which is the field in the OBX that tells you the type?
What do you mean by type, Lisa?
Like
what
rad.
Michelle was like cardiology, lab. It was a high level set of categories.
Yeah, I got to just get it to it. I'm not in that.
Me
system
too.
right now, but I can pull it up.
Do you think there is one, Michelle?
I know there is, for sure, because we used it to determine how we would display the V2 messages in the user interface, because radiologies are generally transcriptions. So you're going to want to display that differently than a lab result. And we use that segment specifically. We don't do any LOINC mappings at all to display that properly. We actually count on the segment.
Yeah, I know what you're saying, Rachel. I mean, we did the same. It's like when we did diagnostic imaging versus radiology versus lab, even in the certification, there was a field in there. I just don't remember which one it is either.
I'm trying to pull it up, so hopefully I'll have it in a second.
And you think it was in the OBX though, not the OBR?
Well, there's one in the OBR as well.
Okay.
But we carried it through in the OBX as well.
Got it.
Is there an issue of where these go? Like, if you're talking about a laboratory test, I think it clearly goes in the results section. But when you're talking about some of the clinical tests, is there guidance to say whether it goes in the results section or in the physical exam section? Because maybe the guidance needs to be different in those two sections. Like most of what we're talking about, we've observed when we're sort of doing multiple levels of nesting, in the physical exam section. I don't know what clinical tests people are deciding to put into the results section, but it seems like there needs to be guidance on what goes where.
Yeah, I know we haven't historically provided a whole lot of guidance necessarily on what goes in what section, because you can put any entry anywhere, but I know that over time we found that to be a valuable thing that the industry wants. And so for example, if you're doing a clinical test that would be whatever, testing reflexes, that's a clinical test, and that seems like certainly that would be more appropriate in a physical exam.
Right.
And so I think I think that you're right. I think it would be helpful to give some general guidance. I think it would be just a big job to do anything like supporting validation. So that would, because then again you'd have to have a terminology service that's going to say, okay, this code is a reflex test, and it shouldn't be in the result observation. It should be in the physical exam section. But I think general guidance does sound like it's warranted.
And I would make a guess at that. I would think that the things that we decided that go into the results section, the LOINC codes would probably work pretty well. The ones that go into the clinical section, that's where LOINC falls apart, and that's where
Sure.
SNOMED is much better. I would looking at it through that view, I think we would find that kind of division of codes.
Well, to Gay's point though, I mean, and I did look at this, and stop me if I'm going off topic and if we need to move on, but I mean, we looked at doing a LOINC. So what Gay was talking about is you can have the result value as a CD type, and then you can put it as a SNOMED, but I couldn't find a LOINC code for just visual acuity or refraction by itself.
Right.
Now, if we came up and said, well, there's 1,000 of those that we need to enter, we could get those added to LOINC. So we talked about the process for doing that, and if that made sense, then we could put everything else at the value level. And
But if
we would
I think that's a good, that would be a good approach. Of course, it is a project to do that many LOINC codes, but it's also a possibility, and LOINC is generally, open to these projects.
Yeah, definitely.
I don't
so
I don't know how long it takes to do that per code for LOINC, but I can tell you there's going to be hundreds of them, if not thousands, that have to be done.
That's my
Well,
that's my
it
worry.
would be like a
but-
single project, right? And so it's not, I'm not saying it's going to be overnight or anything, or even, by the time you would want to ballot, and possibly not by the time you would want to publish, but potentially, I mean, or maybe it will be the next round, but putting together a project for missing LOINC code it seems like it would be certainly a valuable thing. Interestingly, I'm not surprised that SNOMED is more built on from an ophthalmological perspective.
Yeah,
because I know there was a special initiative.
It was designed specifically for clinical terms. That's what it was.
So why
created
No,
for.
I know that there was a special initiative that was an ophthalmologist I know worked on in SNOMED to get the SNOMED terms in there.
All right.
So why wouldn't we just allow the SNOMED codes to work?
I have to put a stop. We're running over.
I guess I have one last question, if I can, and I don't even need an answer, and we can talk about the, where in the previous deck that John and I did this morning, there was links to where USCDI, you can get involved in the USCDI V4 discussions. And so I guess I'd refer back to that, and please, we'd love to have folks participate, as vendors especially, in the C-CDA design of USCDI V4. So please attend on Thursdays. The last question, sorry, Linda, I'm taking your time.
No worries.
Given what we talked about here, and I'm not looking for an answer, is would people think there's value in creating and differentiating the result observation going for the ballot in January 2023, keeping in mind from a terminology perspective, that observation code, the U.S. core clinical test subsumes U.S. core lab results and is derived.
The good people of Texas say yes.
Yes, 100%.
Just know that, creating those two profiles is not going to solve the terminology issues.
Right.
And
right.
that's
Got
going to
it.
be able to tell you what to do where. So
You're
food
just
for
gonna have
thought.
to do that part regardless. Okay.
Yeah. Food for thought. And then
So-
I will now hand it off to Linda and I will stop
So
sharing.
I'm just going to say real quick, we are deriving the OBX from the OBR. So our system does it, and that's how we handled it. So there is nothing in the OBX.
What's
But the
in the
result-
OBR that you're using?
It's a segment. Let me pull it up. Sorry, I didn't pull it up. But you
It
can
has
take
to be
this
an
one.
element in your OBR, right?
Yeah, it's gotta be like, say like OBR and then a number.
Yep,
Right.
OBR, I'm looking.
All right, so just
I'll tell y'all in a little bit. Y'all keep going.
Alrighty.
15 minutes, then we'll have a break. We're stealing 15 minutes from Dee Dee's presentation, and she has said she's okay with that.
All right. And I doubt I go 15, but one never knows. Are you seeing a screen that shows an Ultra Edit editor?
Yep.
All right. So when we last left the IAT earlier this year, this was the example that we had created in the payer section under it's a policy activity. I'll show you that in a second. And we thought we had sort of defined a insurance card, and we represented on one policy activity the identifiers for both the medical and the RX, which contains, in addition to the subscriber ID, which from what we saw most of the time was shared, it contains an RX group, an RX bin, and RX PCN. And we use this special thing identified by, again, our friend Matt S., who's very popular in the IAT this time, helped us with remembering how that was added, that SDTC extension was added. So we took this to the examples task force, and I think Brett was concerned by all this elaboration that had to be done, and it had to be done just to say which group was which, belonged to which one, which group number is medical, which group number is pharmacy, drug. And so he asked the question, what did the fire group do? Because we know we're not fire, but we also know that we're supposed to be thinking about and aligning with, philosophies that fire has taken on. So I looked at the Karen insurance card IG, and there wasn't guidance around what they did with the insurance cards. And so we reached out to Mark Roberts, who worked on this, and he thought they modeled them together, that they put them together, and like we did. So when you look at that in the coverage resource in fire, that's easier to do because there's a single subscriber ID up here. But then down here in the class grouping, you can have multiples of these classes, and the value set for class, whoops, I jumped. The value set for class has group, which will be used for medical, but it also has enumerated the RX types. So it looks really, great for RX and medical, but when we met with the Karen group and we had this discussion, and they started saying, well, what if your card has vision on it? Because you might have two group numbers, and that's sort of the point we've gotten to with, at least with Karen. We have another meeting with them. Brett was out when we met with them last, and we brought in Frank. Can't think of his last name right now, but from Point of Care Partners, and he'd written some comments because of the work they did with pharmacy in another fire IG. And so we're going to meet and talk about this again. I feel like towards the end of the call, they were leaning towards a single coverage for, I'm going to use this word because I can't come up with a better one, but for type of coverage. So what I mean by type of coverage when I say it is medical, dental, vision, pharmacy, long-term care, that concept. if we do go that route, then we have to figure out how we identify the coverage type. I don't think that concept exists in C-CDA, but I don't believe it exists in fire either. They have this concept of type, but type goes to a value set that is sort of all over the place. It will have things like dental, and you know, it says dental care policy, but then it also has like health insurance plan policy. So if if the contract is bought like this and includes dental, what does that really mean? There's also other levels of concept in here like HMO, you know, and it's kind of a mixed level of information. When we've teased it out and talked about it in other discussions, there's at least 3, maybe 4 levels of concept that are built into this one combined data set. A lot of people are running into issues with this, not just us. There are people around quality trying to figure out how this should work. Some groups just sort of say, if it's anything, just use HIP, but that's not useful when you're modeling, when you have to distinguish between, here's all my identifiers for vision, here's all my identifiers for pharmacy, etc. So definitely more to come on that, but that is really where we are at the moment, is trying to figure out if they should really be put together like this with different, you know, these identified by, which, I mean, just looking at it, it's hard to read. Dave Carlson, who was at the last IAT, pointed out a few times that we really are only having to add this identified by because we, you know, and repeat everything down here that we put up here. So it's a lot of redundancy. And so we're waiting for guidance around how they'll do it in fire, and then I guess backport it to the C-CDA templates and align it that way. If we do have separate coverages, you know, there'll need to be discussions around how we delineate that this is the medical versus the pharmacy, etc. I think that's where we are at the moment. I don't think there's any more, Jean, so I can give the presentation back unless people have questions. All right, either I've dropped or there are no questions, so I'll quit sharing.
No, I know exactly what you're saying, Linda. I've been there with processing 270, 271s, having the plans, you know, at different levels. It gets very confusing.
That's a really good input, Jim. We were trying to understand that around 270, 271. Do they elaborate it by medical, dental? I've seen the response in
they do, yeah.
Yeah, go ahead.
They use different codes. So they have a coding scheme that identifies it as vision or dental or different categories, but I think it runs into the same problem as what you're having. So if you have a healthcare plan that includes dental or vision, you would put it under HIP. But what if you have, you know, like a drug card and you want your dental and your vision and that to be independent? I think they run into exactly the same problem. I haven't looked at it for a while. I implemented it years ago, so I have to think about it. But
I'm in that same boat. If you'd asked me a decade ago, I'd have a better answer. But yeah, because that's one of the things Ryan from Karen said. Well, surely they solved it in ANSI. I mean, in X12. And
no, they didn't.
They didn't.
No,
it's not.
X12 goes so far back. If you're looking at 501 and the different versions, we were trying to do it specifically for vision, and we had difficulty because sometimes the vision plans are under, you know, other types of health benefits, so it's really hard to capture those details.
Yeah, and we were talking about that too. We were trying. I did a session with Pi on how you end up with a coverage card. Basically, I had them, you know, like this employer decide they're going to offer coverage, you know, and then had them talk me through how that sort of happens in fire. And it's interesting, there is a contract, obviously, that's associated with an insurance plan. And I don't think it's quite modeled right, because in insurance plan, so the contract says you bought this insurance plan. Then under that insurance plan, you can have 0 to many, theoretically at least one, coverage. And then, so we were trying to say, well, and the coverage has a type, but there's no code value yet. It's a very immature resource. It's only a 0. But we were trying to understand, since it doesn't have a type here, and then the latest version of coverage in fire links to that insurance plan, but this is a many, right? You can have 1 to many coverages. So if you have many coverages, you're linking to the single insurance plan. And how do you know which coverage?
Well, that's a good point. Well, now you're bringing up what I think is more of coordination of benefits, but then, because I mean, does that one plan for the same patient or multiple plans across? Okay, so then, yeah.
Oh,
okay.
I see what you're saying.
Yeah.
The insurance plan was what was purchased by the employer. So many people will link to that, will be covered under that insurance plan.
Right. Okay.
But the insurance plan can have 5 coverages, or let's say 4: medical, dental, vision, and drug, right?
And drugs, yeah.
So you can't model all those the way it is today in here, because they are very likely not all going to have the same subscriber ID. And
then you've got, in network and out of network. There's, yeah. Okay, now I see what you're saying.
So I don't know how you can take a coverage resource and link it back to an insurance plan unless they thought it would be 1-to-1, but then why would the insurance plan allow many? So anyway, the many, I think they may have modeled it for many, because, with your employer, every year you get to choose whether you want HMO, PPO, youth for service, or whatever, different options.
Yeah.
So that maybe the premise was that this insurance plan was modeling that under coverage.
Well, or it could be different countries, because see, I'm in Canada, so I can buy 2 insurance plans. I could get one from my employer, but I could also out and just go, buy an independent Blue Cross Blue Shield
But that would be 2 insurance plans.
That would be 2 insurance plans.
One would be a contract with you and the insurance company probably, and the other would be a contract with your employer. Well, you're Canada, but
right. But then you'd have to know which is primary, secondary. Yeah, you've brought up a very sore spot for me.
I think it is. Yeah. I think it is for many. I think this area really needs some focus and thought. And the United States doesn't do insurance consistently with the rest of the world either. So even if this worked beautifully for the world, we may still have challenges in the US.
Yeah.
But, so once we get past the one insurance card, one coverage question, then we can figure out how, or not, how we model it in CDA.
Right. Wasn't there a project, Lisa, where they were doing this to do with insurance coverages, and they were trying to map the X12 to CDA? I don't know if they were trying to do it to fire, but I'm pretty sure there was a project related to that. Interesting.
I mean, I think this has always been unsettled. We've tried for years, and I don't know, Linda, go back 3-4 years we've been trying. And the part that confuses me is, how did these data elements make it to the level of USCDI? I think they came in the scene in V3, right? USCDI V3, health insurance information.
Yes.
It's so unfigured out.
Yeah.
Well, but it has to, for some of the CMS policies and things to work, you have to have coverage, right? So I'm thinking that's why in the ideal world, ONC has said, in the ideal world, they'd love to have data that has already been created in the implementation guides, and they would adopt it, right? They want it matured, and then they'll adopt it. But not necessarily. There may be needs that they identify that are not yet mature enough, that need to be matured. And I think we've certainly hit that here. It's a little confusing too, because insurance plan belongs to patient admin, And these
Right.
other resources belong to financial management. And anyway, never the
Yeah.
twain shall meet or something.
Mm.
I've tried, as Lisa said, I have tried to get to understand and get agreement on the payer section modeling from both SD and FM. And SD was like, FM should really think about it. Should be the modelers for it. And then FM said they wanted to model it first in fire, and then they would essentially realign their payer section. So Gay, I don't know if it's something you want to undertake, but this is something that I feel is certainly broken today in C-CDA.
Well, and
Absolutely.
and it's going to be really important, as we go to, trying to embed all EHR data into a CDA as per, the rules.
And implementers are using the CDA guidance that's out there right now for payer. So that's being utilized and being implemented. And if the final rule is named V3 of USCDI in the next month or so, do they also have to name a IG guide to go with it?
Who? Say that one more time.
So in the final rule for CMS, ONC, they have V3 of USCDI named. Now, if that goes into a rule, proposed rule, if that goes into a rule, do they also name an IG guide that we should be following?
Well,
coverage
wait a
is,
minute, and I don't know, Gay may know better than me on this, but my understanding is before they can move the floor, they have to have it. They have to do it. They would have to do it in regulation to move the floor up, as opposed to the SVAP process, which says any willing implementer can adopt V3 now. That SVAP said, if you want to use V3, you can. But a rule, like you said, a final rule would have to name a higher version to move the floor up to everybody having used that.
And the proposal says that USCDI V3 is my point, and that says there's payer data in that. So what are we doing from a standards perspective?
Well, and just the data elements that were named in USCDI are modeled, and there are places for them, and they work as well as they do in US Core. I'll put it that way. But I think there's a lot of work around it, and it's really hard to get the payer community to explain to you how this all works. And I've tried. I tried years ago with FM, and I tried this year with Pi, and it's very confusing.
And Linda, I'd like to add one other thing. I over the course between IATs, I was also working on another notion with Dennis and Jim and talking about future appointments, so that in the plan of treatment section, if somebody was pregnant and they knew that they were going to need to come to the next 8 appointments that would be lined up for them, to write down those planned encounters. And we got into the topic of whether it's feasible to imagine a CDA document that's generated from the clinical side of a practice's system, having scheduling information, when most of these systems house that on the practice management side of the system, and scheduling information might not even be available to the system who would be responsible for generate the clinical document. And I'm wondering to what extent that could also be a problem for health plan, payer coverage, whatever you want to call it, health insurance information, is if we put a payer section in a clinical document and expect it to be generated by a system that has the clinical information, will it even know and have access to the payer section required information in order to populate it?
What we found when we first started doing some of this work in Da Vinci, now, 2017, I had 3 experts, one, Michelle Miller, who happens to be my boss now, and from Cerner at the time, and Danielle Friend from Epic, and Emma Jones from, and you guys all know these people probably, they're brilliant. And it's how closely tightly coupled those EHRs are, you know, if they're using the full system, and then how tightly coupled they are. When the systems aren't tightly coupled, what the belief was, at least back then, was when a patient is checked in, that coverage information does go to the back office or front office, however you want to call it, but where the medical record is. But there can be challenges with that because it may, you know, you get a lot of insurances sent back there, but you never necessarily get them termed. And so it depends on how it's integrated. If it's integrated per an encounter and you get just the insurances for that encounter, you know, so there was a lot.
And are they
a lot of
on the
things
lab
that could
results?
happen. Sorry.
Are they included in the lab result fee? Because if so, then that's clinical data. It's helping the physician make a decision on where they should get their lab results done.
All right, I'm gonna cut in. Sorry, guys, we need to move on. Dee Dee, we're gonna steal some time from Dee Dee, but we can't steal all of her time. So I'm just gonna give a 10-minute break for people to get more coffee or tea or what have you. And then we're gonna be back with Dee Dee talking about data usability for half an hour.
So Canadian of you. I am drinking iced tea though.
Is it sweetened or unsweetened?
Unsweetened. I don't live that far. I don't live as far south as Rochelle.
Yeah, mine's unsweet now because I'm older, so it used to be very sweet.
We have a phone number in the waiting room.
It's me. It's Matt.
Okay, and then I'll let it in.
Did you find the element, Rochelle? I'm really curious.
I did not, but I am I'm just very concerned now. Now I have to go log into a system and see where I have it because I'm looking at Quest specs and I've looked at HL7 specs and they don't call out type, but I know I've seen RAD repeatedly in those messages. So I'm going to go back. Jessica found it actually in the MSH segment, but that would just be because we labeled where it was coming from. It has nothing to do with, you know, what type of result it is. So I'm going to track back through what I have.
And you sometimes get radiology and OR used and transform them to MDMs and stuff like that too. So, right? Yeah.
Exactly. So I'm going to find it. When I find it, I'll let you know.
It's like we've all been in that same transform role, right? Different companies.
Right. Exactly. Like, how do we make it work? I think is what we always are trying to, you know, make it meaningful. So.
Okay, I'm going to show, we've got some more vacation photos that I'm going to show, and I think Linda, yours are going to be up next. So I hope you can stay on or you're there.
I'm here.
Excellent, because we need commentary.
Especially since mine to have no people in them.
No people. I noticed that. All right.
So we
Here.
took what we thought, what for us at least was a bucket list trip, which was to fly to Seattle, and then we did an Alaskan cruise. I've now been to 49 of the 50 states, and those of you playing along can guess which one I haven't been to. What?
Hawaii?
No, I've been there a few times.
Oh.
But you can see in that one the top picture is the Space Needle, right? And then that's an eagle in Sitka, Alaska. And when we stopped there, we went in Endicott Arm and saw Dawes Glacier, which that iceberg is from Dawes Glacier up at the top. The main glacier there is Mendenhall, and it's awesome to see. Now I want to go back and see, I think it's called Hobart Glacier. But anyway, yes, this was my 49th, it was the 49th state, and it was my 49th state to visit in Alaska. So I'm still looking for the 50th state. You can share it in chat if you like.
And
where?
If you're Facebook friends
what's our 50th state is what she's asking.
yeah, if you're Facebook friends with Linda, you'd have been able to see her cruise pictures. There were some really nice pictures there.
Feel free to friend me. I won't be hard to find. Michelson, if you spell it the right way with S-E-N, is rare. All right, I'll tell you, it's Maine.
Maine, oh, that'd be tough.
Yeah, I couldn't get it with the Alaska cruise.
I have to hit that area. My wife's been up there, Vermont, Maine, and all that area, and I haven't. So that I got to get that area in Oklahoma. And there's 3 or 4 states around Oklahoma.
Next time WGM is in Baltimore, we'll all have to take a road trip up the coast.
I want to
Not
go.
Baltimore, Boston is what I meant to say. Baltimore would be even more of a road trip.
Yeah, let's have a WGM in Maine. Let's all go there.
Nice. Okay. And then is Catherine still with us?
I think she dropped off.
Okay. This wasn't a vacation for her, but it was I think some hiking that she had done, which I meant to show this earlier, but we didn't have a long enough break. Lisa, are you here?
Yes, I am.
All right. Well, we've got two slides of your pictures because they were because I'm the dog person, so I had to include the picture of Willie Nelson. He's pretty
Yeah,
cute.
that's my brand new puppy.
Oh my goodness. He's
He
adorable.
was 8 weeks old in that picture. He's 10 weeks old now.
What is he, Lisa?
He's a Cavalier King Charles Spaniel.
Oh, they're so sweet, so beautiful.
Yeah. He weighs about 7 pounds right now, and will supposedly stay under about 14. So he's pretty tiny. And he's sitting on my lap being a pistol right now. See if I can turn my camera on. And then we had a big family reunion last weekend, and that's all my nieces and nephews and their kids, and Mark in the tie-dye next to me. And I'm in the red bathing suit there with the hat on and the sunglasses. But we had perfect weather and a really, really nice family visit on the beach in Rhode Island.
Lovely, lovely.
Is your daughter who rides horses there?
No, because she was at a horse show in Maine. So summer is really busy for her. But earlier in the year, I took my goddaughter Maisie to Paris early on in her education, probably like since elementary school. I always promised that if she graduated from high school and got into a good college, that I'd take her to Paris to celebrate. And she just finished graduating from high school, and she's on her way to UVM as of Thursday. So we did a nice trip for about a week to go see all the main sites in Paris.
Very nice.
I love this one, Lisa.
That was my like Sound of Music. I don't know, I was doing The Hills Are Alive or some Sound of Music thing when I was taking that.
Yeah, yeah.
Julie, it made me feel like Julie Andrews to be there.
And that's what you look like.
Yeah.
Lovely. Okay. I think, oh, wait, this is an important one. Dave, are you there?
No, Dave had to drop off.
Oh, gosh. Okay.
Yeah,
well,
if you remember, he talked about, it was at the working meeting that he talked about Big Elvis in Vegas. So it's this guy who's quite large, but he does a fantastic Elvis impression. So he went there when he was in Vegas, or when we were in Henderson.
Nice. That's cute.
What I like about you.
I wanted to go back to Jean. I think you weren't on this morning when we started this. And
Yeah. So Barb and I, we went to Amsterdam for the HL7 board meeting, and then I was in Lisbon, Portugal for a trade delegation, a Canadian trade delegation, and then we went up to Fatima. So one of the Marian apparitions where the Virgin Mary appeared to three young kids, and then the fire pit on the right is, we just took my grandkids, all of my part of the Duto clan. We went down to Drumheller, where there's a huge it's Badlands and there's dinosaurs, there's a big dinosaur museum. So we took and our 4-year-old, it's incredible to see things that you've seen before but bring a 4-year-old with you, and it's amazing. And the fire pits, they didn't have permanent fire pits, they wheeled them to you and they're welded to lawnmowers. So it's pretty cool.
I was wondering what that was.
Yeah, so we had fantastic fires every night in this portable fire pit. Yeah, that's my wife and I think it's Batalha in Portugal. Some amazing churches, and this one was built, the prince or the count or whatever prayed to God and said, if you let me win the battle, I will build you a huge church. And then they won the battle. So he built this huge church.
Nice. Okay, and then I think we've got a couple more minutes, and Matt sent these ones in just today. So Matt, are you there?
I am here. That is a staycation in New Orleans. Everybody else is doing their vacation. I stayed in place for July 4th. That is myself, my girlfriend of about 4 years, and her little nephew, who is about 6 years old, his first time going to the aquarium. And so I haven't been to the aquarium in at least 2 decades. Last time I went was probably high school. So we went there, checked it out. It felt different. I think it felt smaller, but it still had like an hour long for the whole walkthrough. There's no way for you to get out though. Like you can't exit midway from what I could tell. You have to walk through the whole thing from beginning to end. So very enjoyable. The next thing is the insectarium. That's probably be the next thing we give a go.
Okay, and what's this bird here?
That should be a falcon, I believe. It's one of the first things you see as soon as you walk into the aquarium side of things. And then there's a white alligator right after that. I didn't get him. He was pretty chill. I almost didn't see him, but I saw him at the corner of my eye. But I caught the falcon. The falcon caught my eye.
Nice. Lovely. Well, I think that's it for.
Yeah, let's get to Dee. Dee's going to talk to us about data usability taking root.
Yes, and good afternoon, everyone. Let me start sharing my screen. Sorry, I have 2 monitors and I'm trying to make sure I'm on the right one before I get started, but share. All right, hopefully you're seeing my screen. Let me go into slideshow mode for you. Are you guys seeing the right screen?
Yep.
Yes.
All right, perfect. Just wanted to make sure. All right, and let me turn my camera on too. Sorry, I should have done this earlier. Okay, hopefully you're seeing me as well. All right, so I'll try to keep it brief. I gave a little teaser this morning for some of those of you who were on earlier, but the Sequoia project, just kind of a primer, giving you a little background. Our board of directors prioritized data quality and usability as a real focus for us, having achieved some success previously in doing content testing and trying to move the needle on the industry. So just a little background. I operationalized a content testing program in 2018 for a very large network known as the eHealth Exchange. It took us 4 years. In 2018, 100% of the organizations participating in that network failed, just being tested against meaningful use validation. And about 75% of those organizations were creating C32 documents. So that was a very old 2011 edition of meaningful use. 4 years later, fast forward, 96% of the organizations on that network today are maintaining passing. And I have the roles reversed. Now 80% are at the HL7 C-CDA 2.1 version, which is where USCDI starts from, for those that may not be following along those. And then trying to move that needle, we also found that there were usability issues. Things like there's a lot of duplicates in this world, because when you go out and query for information in the normal use case, you query retrieve, you may get the same data from multiple sources. So there's a pain point of a lot of duplicates coming in, bloated CDA documents, Unfortunately, everybody tried to squish everything into a CCD document, which was supposed to be a patient level summary document. It was never supposed to be made for encounters. They're trying to put all encounters in it. So I've seen documents that are hundreds of encounters all squished into one, and then some that use that for encounters, but didn't include all the information, like a discharge summary that may be needed, like Catherine and Lisa presented about earlier, and so forth. So we organized a work group. Our board approved, and we created a charter for a work group, launched it in October of 2020. Took us 2 years. We had a solicitation for all the pain points from the industry. Those resulted in about 34 different pain points, use cases of here's something that really is a problem for me in my organization. And we took 2 years until 2022 to publish an implementation guide, not creating new standards. So Sequoia doesn't want to compete with HL7. HL7 is the SDO. We depend on very heavily, as well as IHE that was mentioned earlier by some of the eye care folks, but we needed to kind of move the needle a little bit further. So we released an implementation guide. I have 2 co-chairs for that work group. Dr. Adam Davis, who's a practicing pediatrician for Sutter Health out in California. So the ambulatory side is represented from a user perspective, and Dr. Bill Gregg from HCA Healthcare, which is the largest hospital system in the United States, representing their organization, and their vendor is Meditech, and Dr. Davis's is Epic. So we had a couple of vendors in there, we had some users in there, and we put out a guide. But we didn't want it to just do like a lot of implementation guides do, sit on a shelf and collect dust. So we created something called the Data Usability Taking Root movement, because we want to make version 1 that we published last year take root. We're very happy and grateful that AHIMA, the American Health and Information Management Association, partnered with us to actually go and help us with the deployment efforts, in helping not only, for instance, we're going to be hosting a workshop at their annual conference. So it is a true partnership of us doing things across the board to try to move the needle across the industry. So what I've just kind of told you is summarized on this slide, and these are already up on the website on the Confluence page for you to download. But 3 years in the making, here we are now, here it is almost September 2023, 2 years of public input, because we took 2 years to build the guide. We had 266 engaged organizations and 378 subject matter experts that contributed to the work over those 2 years of input. And again, our motto is, it's one thing to get the health data moving to the right place at the right time, but it's quite a different thing to make sure that data is useful. And we have some examples that we'll talk about here in a few minutes. So we have the pun of taking root because we are the Sequoia project, the Sequoia trees. So the pun there, it's time for this guidance to take root. So just to be clear, the movement, the taking root movement is kind of our deployment efforts of trying to get the adoption of work. But we've actually already started on version 2 guidance. So we started meeting again in February of 2023. And we meet once a month, the first Thursday of every single month. And we are now developing input for version 2. There were a lot of things we left on the parking lot in version 1 that we need to still address. And that's what we're working on now. But the taking root movement, this slide, I kept getting lots of questions. So I had our marketing team slick this up a little bit. So if you think about the right side of the screen, it's building a community of practice. That's what we're trying to do, is convene users, vendors, the implementers of data at a source level to try to get it corrected at the source, rather than having to have an intermediary or a translator or a mapper or something else, trying to see how much of that can we get in the right way. So we launched that. We've started holding roundtables. We're going to have our second one actually tomorrow. We are providing technical assistance. We're going to plan for a testing platform so everybody can hold each other accountable to making sure they meet the rules of the road. And we're going to have in-person convenings. We're going to have a summit in September 6th. And we've asked for participants to kind of come in as a supporter, meaning you're just going to support it. You're going to help share the word. You're going to ask your vendor to implement this, because you can't control your vendor by making the vendor do it, but you can ask them to do it. An implementer would be somebody who actually controls the development of a platform, and then sponsors like AHIMA and others who are signing up to work alongside of us. So why would you want to join it? And I'm not trying to do a sales pitch, I promise. I'm trying to just share the word, and then you can decide how you want to share this internally or with other peer organizations that may benefit from it. But we want to make sure that we can improve the patient outcomes, literally. You know, good data, complete data improves those outcomes, but we want to also reduce that clinician burden, because that's what we're really trying to also do, is help change the paradigms of how can we make those electronic health records work better and smarter. And it's just the right thing to do in general. The guide that we published in 2022, December, tackled 6 topic categories. So on the left-hand side of the screen, you'll see data provenance and traceability changes. There's actual guidance in there saying if you updated labs, then include when you did it in the provenance in that section, because those labs may be with a whole bunch of other things that were done as part of an encounter itself. So trying to think about pragmatic guidance of how do we make sure to make the data as useful and trusted as possible, effective use of codes, reducing the impact of duplicates, data tagging to be able to slice and dice and search for information like COVID. When COVID was around, how do we look for those diagnosis codes and things like that? So these are the different topic categories, and we kind of covered 3 different overreaching use cases: provider to provider exchange, and this is data moving truly between organizations, different providers for transitions of care or some sort of care management, provider to public health or public health back, and healthcare entity to consumer. So trying to get that consumer engagement as well. And there are a couple of the 6 topic categories that deal with consumer engagement or healthcare entity to consumer. There's 2 of those that are covered there. Public health, there's guidance in 4, but in provider to provider, there's some guidance in all 6 of those, an example. And in these slides, that top link, version 1 implementation guide that's underlined, that's a hyperlink to the actual guide itself. Now, I'm not going to read these because these are leave behind, but if you're a public health person and you're representing public health, why would you want to do this? What it's going to do for me? These are some of the talking points that can help you as you're discussing it within your organization. Say, okay, we're having some problems with exchanging with public health. Here's some things that we could do to help make this a little bit easier. And making sure that the organization can be listed and things like that that may be needed to enable the clinical notes that may be important, or linking the narratives as needed, because some public health can benefit from that. Providers, there's topic category, kind of some bullet points for talking of why would you want to do it if you're a provider organization or a hospital health system, ambulatory provider, etc. If you're a vendor, and I know we have some vendors on here. If you're a consumer, what are you going to get out of it? So all of us are consumers, all of us are patients, and we probably have some responsibility to take care of children or parents or aunts or uncles or friends or somebody. So there's benefit for anybody and everybody. And a health information exchange or health information network. These are value adds that they have, because AHIMA also wanted to make sure that we talked about not only our organizations that we were focused on, but also now their operational and HIM type staff. So there's benefits to all stakeholders across all organizations. And we want to really think about usability in all projects. We don't want this to be a one and done. If you're implementing a radiology system, we talked about radiology, imaging, and so forth earlier, this guidance isn't just applicable to CDA documents. It could be any IT project trying to think about how do you capture the data right and make sure the right codes are used and things like that, so that you can figure out how to put it into practice. So we're telling all participants, implementers, supporters, whoever, that you can choose your own pace of doing this. And you need to look through identifying where to start. So, getting familiar with the guide if you haven't already, looking at what could you do quickly. And I use the example of provenance. Provenance is something everybody should be doing for clinical document exchange. You should have the author organization, where did it originate from, and the date and time. Every piece of data should have that in it. And if it doesn't, shame on you. But guess what? I'm seeing data that doesn't have that in it. So those are types of things that if you can just get a quick win by making sure to populate that, or if it's already included in what you're exchanging, claim credit for it. That's what we're trying to do, is raise some momentum and help now start tracking progress. So we are going to have our first summit September 6th, and we're going to help put together what are some potential self-reported scorecards or elements that we could highlight that are being now supported by 80% of the industry, or what are some things that we can do to show the implementation and the movement, because we're hoping to get some some things moving in the next 12 to 18 months so that when version 2 comes out late 2024, we have something else to come in afterward to have continuous improvement of data. So that incremental approach, again, elevating it to be being data usability in all IT projects. And then really thinking about how can we inform, of course, we can't guarantee any of this, but EHR Association signed on as a supporter, Civitas, which is a large group of networks, signed on as a supporter. But how can we inform governmental frameworks like TEFCA in our recognized coordinating entity role? How can we at least say, here's some things we're doing. Maybe we should now start mandating this for others in the future, seeing some things that we've proven around lessons learned. So what we're trying to do again is provide technical assistance from the Sequoia perspective, community of practice, which is bringing all of you are potential stakeholders. So bringing those together, convening those roundtables, discussing how can we help share lessons learned, but also what are some collateral components that we can help, like what are some checklists that you could have as if you're wanting to check to see how could I implement this in my system or my organization? Are there some talking points to help you sell it within your organization as something to focus on? And then of course the testing platform. So the testing platform and the technical assistant kind of goes hand in hand in building that community of practice. What really makes us distinctive, because that's been a question we've been asked quite a bit, is we are not creating new standards. We are just elevating and amplifying existing standards that are out there today. So we want to address pain points from the end users on the front line, but thinking about this as how do we empower those actors or those systems, those data sources to really make that change happen? And how can we help empower them to solve that shared pain point? If it's something with a partner that they're having, maybe they can say, hey, partner X, this is something you might want to look at because there's some things here that we're having that maybe this could help you with. So sharing this, getting the word out and helping create those early adopters, because we very much believe to move a market, you really need market movers to think about this continuous improvement. So these are the 3 levels of engagement. Supporter, really, there's no money for any of these. So we're not asking for money on these things. Sponsors, we might, but supporters and implementers, not so much. There is some thoughts around, do you want to just brag about it? We have several supporters out on our website already. We would put a logo out there saying, yes, you're supporting it. Implementers really will pledge to actually implement. It could be something you're going to say you're going to implement in 18 months. It doesn't have to be tomorrow or next month, but what's a timeline in helping try to articulate that to the industry? So we're going to try to work directly with vendors like Meditech and like Oracle and like Epic and Athena Health and eClinicalWorks and all those other EMR vendors to try to help hopefully work with them so that they can actually do some sort of communication loop to their customer bases. So our planned deliverables, again, is to continue these roundtables to help these early supporters, to help everyone get on the same page and leverage the information and the guidance and start talking about it. But really the summit that we're going to be hosting is where we're going to kind of then figure out how we're going to operationalize that. What are the priority items that we need to start providing to the industry to be able to have that technical assistance that's needed? How do you improve that implementation for the community of practice? And then the testing platform and then the support services. So this is our roadmap over the next, this is a continuous improvement. I heard John DeMore mention earlier, this CDA documents, fired, bundles, any way data is being exchanged, we're trying to make this guide be technology agnostic. The first version guide, I'll be very honest, was somewhat focused on CDA documents because that's what's being exchanged in the real world today. 99% of what's being exchanged is with CDA documents. But we want to take the roundtable, the summit, and prepare ourselves to launch really full force into 2024 to expand the participation, help develop some guidance around V2 and FHIR, because guess what? Data is being exchanged with those methods and payloads as well. Labs are not going to be moving off V2 anytime soon, I don't believe, for instance, and try to hopefully set some expectations of where the implementation's beginning across the industry and continue to grow the movement leading into 25, which will hopefully then have some new guidance coming in that's now new focus that folks can have, and continuing to grow the movement and the community and practice in general. So this is the hyperlink to where you can get more information about joining the Taking Root movement. Again, we're trying to just create that buzz and momentum, because it does take a village to make any of this really happen in the real world. So with that, I'll open it up, and I think I've got maybe a few minutes, maybe 5 minutes for questions. I think I only took about 18 minutes, so. Any
Dee Dee, this is
questions?
Lisa. Thanks so much for sharing this information. This is really exciting. We talk about trying to get impact out of all this hard work we've been doing for so many years. What kind of guidance or what kind of incentive do you have to get organizations to start requesting specific document types, not CCDs, but for example, discharge summaries? It just seems to me like everybody is equally focused on just the CCD, and that's all they think to ask for. Are you doing anything to encourage your queriers to ask for other types of documents?
Yes, there is guidance in there. And in fact, what Texas Health Services Authority and Catherine and her team put together, we added their guidance of what they feel should be in a discharge as an appendix. And that appendix is pointed to by several of the topic categories, saying you should include, for instance, narrative information needs to also be included in that discharge, or in that referral note, or that progress note, or however that implementation of that vendor's technology has it being used. Like some vendors use progress notes, some use referrals, some use discharge summaries, but it's just beginning to. So that's what we're hoping to do, is by building this community of practice, getting the users to say, like Texas, hey, CIO from all those Texas hospitals saying vendor A, B, C, D, E, however many vendors there are, we want you to do it this way. So by Texas helping reinforce that, by us having something they can point to, we're trying to work together with the industry. But I'm not saying we've done it yet. We're starting, and that's why we want you guys to help join this, to help us be successful at it, I guess. Other questions? And we're a nonprofit, so for full disclosure, those who don't know about Sequoia Project, we've been around since 2012. We were originally formed to take on the Nationwide Health Information Network at that time. ONC had started it, and we've kind of grown over the years. We've launched Care Quality, which now are both separate organizations. So we are a nonprofit. Care Quality is a separate nonprofit, and so is eHealth Exchange. So once we incubate, we're really good about incubating projects, as we call them, and then spinning them off to where they're a sustainable, business model, and having them, go off and flourish. But with our newest work, all of this work falls under our Interoperability Matters initiative. But hopefully, Lisa, you asked what's the incentive. Doing the right thing is really the incentive right now. There is nothing that points to this guide, but we're hoping that somewhere along the way, vendors and users, if users start putting in RFPs, things like that, maybe we'll start building it through the public-private sector rather than having to have the carrot and stick. But maybe it could inform future, frameworks, policy frameworks and things like that in the future. I know Care Quality is considering pointing to it in the future from a care quality perspective. I can't speak on behalf of TEF because that will be something that we'll work with ONC on. But I think we need to show some progress and some success before we try making those kinds of asks. I'm not going to try to put the cart before the horse. We want to show actual improvement before we try to point to some of this work, hopefully. But other questions? Well, if you have questions at all after you go back, there's an email here, takingroot@sequoiaproject.org, that you can send us an email. Multiple staff man that. If you're interested in learning more about the Taking Root movement itself, this is the URL link for that. And this second one, where it says follow the development of version 2.0 guidance, that's a link to the work group. So the data usability Taking Root meets once a month as a roundtable, and the data usability work group, which is creating the next version 2.0 guide, meets once a month. And we are getting ready to launch in October. We put out a call for participation 2 weeks ago. And we are asking for lab subject matter experts. So we're trying to have a lab tiger team, because one pain point that we really just barely scratched the surface on was lab usability. And for instance, Texas, I'll steal a little thunder there. Texas proposed in May at our data usability workgroup meeting, the need to improve the viewing of lab results. And they were gathering samples across all of their EHR vendors. And they're finding that some vendors, believe it or not, when they get back a lab, the vendor will put all the lab components, all those attributes in alphabetical order. But a physician is used to seeing like CBC data grouped together. They don't want all of those elements that are part of a CBC, a complete blood count, to be just alphabetically posted, because then they have to scroll through all of the stuff to find what they want. So there are things like that that we're starting to focus on. Most of the usability in version 1 guide was how do you generate the data and send it out. Version 2, we're going to start focusing on labs and how do systems receive and display that data a little bit more usable with guidance, hopefully. There. All right.
Dee Dee, maybe some of your people would be the right people to contribute to the examples task force work, so that we have a group that not only can specify what data elements belong in what structural components of a machine processable entry, but then come to some consensus agreement about how to render that information, given what's in the machine processable entry. What's the story that the human should really see to organize that information in a meaningful and usable way?
Yeah, absolutely. And that's the key. So this is not a one and done. Just like you mentioned some highlights of things that's already been changes that are being proposed to help with the discharge summary piece. We're hoping to come back to HL7 and say, here's some examples we need. You guys were wonderful. Brett Marquardt was wonderful in providing an example for our consumer guidance of how some of the data needed to be seen. We needed an example, and you guys helped us have that. And you published it and we pointed to it. So this is a collaborative, work process where we're going to work very closely with HL7, because you guys are CDA, you're fire, you're V2. So we're going to be very much in that feedback loop to HL7, hopefully providing some feedback on hopefully existing derivative works, and then also informing new works as they're being developed, hopefully. All right, well, I am going to give you back 5 minutes then. I thought I could probably do it in 25 minutes, but I didn't know how many questions there would be. So one last call for any questions. Well, I made up the time, folks, Susan and Jean. And if anyone has questions, I'll be around. I'll be on and off a little bit tomorrow, but I'll be on the rest of the day. So thanks so much.
All right, well, let's take a 15-minute break. We'll be back here at 5 to the hour. And it's the ONC presentation and ask the ONC. So you can always use a few extra minutes for that. So 15 minutes and we'll be back at 5 to the hour. So while we're waiting, I had to move my cell coverage. There's a Canadian provider, Shaw. They got bought up, and it was unfortunate because they had my name spelt wrong. They had, and so it was cool. So because all the junk mail that I would get that would be addressed to that person with the wrong name, I know that, aha, Shaw has sold my name to this such and such a company or what have you. Sigh. I think, Jagina, you do that. You used to do it with emails. You'd create new email addresses to give to people or give to company.
Pretty much. I mean, they all kind of route to the same, it's my domain anyways. But yeah, you get to see who's not so great about letting their information get scraped or selling it outright.
When I moved over to Rogers looked at the name and went, "Oh, they've spelt it wrong." I'm like, "Yes," and that was really useful. Can you spell it the same way? Like, no, we need to use what's on your driver's license. I'm like, dang it, Jim. We don't have any more vacation pictures, Susan. We showed everyone's vacation photos. Stepped away.
I guess you'll have to play music, Sean.
Yep.
Make you play something.
Ah, that.
Okay, he's got a few instruments.
Yep.
On his back wall.
I'm not opposed to karaoke if you play something I know. I will sing like you wouldn't believe.
Oh, there's.
Ooh, I have a cowbell.
Oh,
I can join in on the cowbell.
We have a live puppy.
Oh, I just woke him up. Oh, no, say hi, everybody. Say hi, I've been napping underneath her desk. Yeah.
Oh.
Really
And
good.
And what's puppy's name?
Wilson. We call him Willie. Willie Nelson.
Aw.
He's a good dog.
He's cute.
How big,
Nice coloring.
how big will he get?
14 pounds, probably at the max. So, like, he can heel already because he has no choice, It's not like my golden, where the dog takes you for a walk. He's so little that he can't really outrun the leash. So he just has to go with you. But he can't figure out how to go up and down stairs yet. So he just stands there and waits for somebody to carry him up and down the steps.
Looks like he's a pretty chill puppy for being a puppy.
Yeah, I just woke him up from a nap. So once he gets rolling, he'll be a little bit crazier, eating my desk chair and biting on my keyboard and stuff. But right now he's in just like sleepy mode.
My standard poodle, learned to hop up and down the stairs, and so even now, even though he could just regularly walk them, that's how he goes up and hop, 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 hop. Funny watching a 50 pound, standard poodle. Hey, come here. Oh, I gotta put on my video.
My lab does the same exact thing. He hops downstairs. He doesn't walk.
Makes you wonder, they say if you buy a cat or you have a cat with a dog, that you should get the dog as a puppy because they'll always think they're smaller than the cat. So maybe once they learn to hop, they think that's the only way to do it.
That's right.
Nice luck, dog.
Louis
Oh,
Armstrong. Oh, doesn't want to be up.
yeah, my Great Dane puppy will walk up the stairs, but not down, which makes it very interesting.
Okay, how does he get down?
We carry her and she's 115 pounds already. So we
Whoa.
try not,
Wow.
luckily our house doesn't have stairs, but our best friend's house does. So we have to block it and make sure, like, cause she'll follow my husband up, cause that's where the pool table is. She'll follow people up and then we have trouble.
All right.
Kyle, what's your dog? What was it?
Yeah, I was trying to see if you can see. He's very comfortable right now.
Oh,
Is he a lab or a Great Dane? Or
Yeah,
what?
he's a lab.
A lab, yeah.
yeah, the play dog pose. I took a picture of Louis like that. Post on say my dog is poses for play dog, but of course he only reads the articles.
No.
Oh no, you can see my dirty dishes too. Where are you?
Like if they do that, right? They're a bit warm, but they're also completely at ease because they're obviously exposing their belly. If they stick with their butt to you,
Yeah.
then protecting you. Like there's a whole bunch of different sort of pack like.
Oh, really?
Yeah.
I thought it was just farting in my general direction.
Well, there's that too. That's the beauty of having a good dog like that, right? If there's a smell, you just the dog.
That was a Monty Python quote. Sorry.
All right, ONC. We have a bunch of ONC people on. Thank you, everyone. Kyle, Al, Alex, Carmela, Matt, Sarah. Who else? It's a bunch. I think that's everyone who's got ONC. So I'll let you guys get to it. You have a bit of a presentation, I think, and then our ever-loving Ask the ONC questions. So who's going to start?
Yeah, Carmela's got this.
Carmela's got it. Great handoff.
Hopefully Carmela's here.
She is, yep. You may have stepped.
You might be double muted, Carmela.
Or she's
all right, I'll do a quick intro. So my name is Matt Ron. I'm the acting director of the Standards Division in the Office of Technology at ONC. And Kyle, do you want to do a quick intro?
Sure. Kyle Cobb. I am Matt's deputy in the Standards Division. And I think I've met many of you previously. I used to be in tools and testing and certification. So I will hand it over to Alex.
Hey everyone, Alex Contour here. I'm on Matt's team in the Standards Division, Office of Technology.
Next person, you go, Al. Don't be shy.
I guess that's me. Yeah, it's me. Can you hear me okay?
Yep.
Al Taylor, technical lead for USCDI since, forever. And the target of many Ask ONC really pointed questions.
And Sarah introduced herself at the beginning of the day today, so that's all right. So Carmela, it's on to you.
Oh, hi, everybody. I'm Carmela Cuder, and I'm at ONC, as you can see from my background. I'm the branch chief of terminology, content, and delivery, and I work with Alex and Sarah and Kyle and Al and Matt, if he's still on. And happy to be here, and I'm going to be kicking off the next session. And I'm also, in my other life, I'm a co-chair of terminology and infrastructure.
At HL7.
Right, at HL7, sorry.
One of the many who tried to keep Ted Klein in line, so kudos.
I don't know what I can say. I can't even react to that.
I was going to say the operative word is try.
Yeah.
Yeah.
Maybe it's time to hand it over to Sarah for an intro.
Oh, Sarah introduced herself at the beginning of the day.
Okay.
So yeah.
Great.
We love her already because she was here from the beginning.
Are you guys just taking questions or do you have material?
Nope.
We have a short set of material and then we're gonna take questions. It's gonna be wide open.
Carmel, are you going to share your slides?
Yeah, or do you want me to display it?
Yeah,
So-
I'm sorry. I thought we weren't starting till 5, so I thought maybe we were waiting until
no.
5 in case some people were joining at 5.
No, we were earlier, and so we gave you guys an extra 5.
Oh, I did not know that. Sorry. I was off doing something else. Okay. Yeah, I'm happy to. Was that you, Susan? You want to share? I
Yeah,
I
can-
updated the PDF on the Confluence page a little while ago. I don't know if you
Oh,
noticed me
okay.
sliding that
No,
in
I
there.
Didn't notice that. I saw, well, I knew somebody had done something, but it's always so hard to tell.
But that was me.
Okay, let me get that open. Okay, I'm gonna go on mute and then I'll share my screen.
Did I see people, when I came back into my room here, I thought I saw people holding dogs and things like that.
Yeah, and during the break, we were showing off our puppies.
Oh, nice. All right. So what we're going to talk about today, this should only take about 10 minutes, maybe less, hopefully. We're going to go over what's new at ONC. We'll provide a quick overview of the most recent version of USCDI, which is version 4, published on July 20th. We'll talk about some recent changes to our data element submission process, and we'll finish off with the USCDI timeline and some information about EHI that we were given a softball question ahead of time. So before we go into the updates, though, I just want to mention and encourage you guys to attend our tech forum. That's going to be a session on USCDI and the relationship to the C-CDA companion guides and US Core, and that's scheduled for September 28th. So keep an lookout for that. Let's see. Now I'm ready for the slide. So recently, ONC issued an NPRM, which stands for Notice of Proposed Rulemaking. And thank you for everyone who commented. We really appreciate it. We review every comment. And HTI1, oh, see now, I see you have the older version of the slide. So you've got my note to myself in there, but that's fine. We're amongst friends. But HTI1 stands for Health Data Technology and Interoperability. And so this rule is certification program updates, algorithm transparency, and information sharing. Now, if you were on the earlier USCDI session that was at 3 Eastern, you might have heard a question in the chat. And there was some talk about whether USCDI version 3 was proposed for HTI1. And yes, it was. Along with that is release 4.1 of the companion guide. Next slide, please. We also had some discussion about other versions of the C-CDA companion guide that are referenced in SVAP. Now that stands for Standards Version Advancement Process, and that's where certified health IT modules can voluntarily update to and be certified for a version of the companion guide that is different than the one that's in regulation. So right now, and this is on the bottom of the slide, the current regulation requires a companion guide that was published in 2019. But through the SVAP process, a health IT developer could upgrade to, say, the one that was, let's see, release 3 that came out in May of 2022, or the very recent one, which is release 4.1, which is the same one that was proposed in HTI1. Next slide, please. Now, Susan sent us a question that was asked at a previous implementation-a-thon. So we thought we'd put it in here, an answer to it. There was a question about what happens when we test in the certification program, an unstructured document. So a document header is always required, the structured header, but the body, as we know, could be structured or unstructured. So the testing for that narrative portion, whether it be the whole document or it might be a section, that's always done by a test proctor. Let's go to the next heading. I'm sorry, next slide. Oh my gosh. So now we're going to jump into USCDI a little bit. Next slide, please. So USCDI stands for United States Core Data for Interoperability. And on this slide, I'd like to focus on two keywords, core and baseline. So USCDI is setting the floor for the data elements that must be exchanged by certified health IT. Now, we know that when we look at USCDI, let's say it has a total of 90 something elements, many, many, many more data elements are exchanged and are necessary to support safe exchange of health data, but USCDI sets the core. Next slide, please. I'm sorry, it sets the baseline. USCDI matters for a lot of reasons, but here's a summary. Number one, it's established in the Cures Act final rule from 2020. So that's where we enshrine USCDI version 1 in regulation. But it's also required for certain certification criteria. So it sets the bar for what data must be exchanged when, say, you're certifying to transitions of care documents or clinical information reconciliation and incorporation, patient view, download, and transmit. USCDI, the version of USCDI that's in the rule, those are the data elements that absolutely must be exchanged for those criteria for certification. USCDI is also referenced by other federal programs such as CMS Patient Access and Payer-to-Payer API. So there are other, I'm going to say, agencies that are guided by USCDI requirements. And just as a reminder, USCDI version 3 was proposed for HTI-1 in the NPRM. Next slide, please. So here are the data elements that were just released in USCDI 4. Now, this was 20 new data elements. And you're going to notice, I'm sure, that there's icons next to some of them. And these are how we tag when we're presenting to folks and trying to explain why we add certain data elements, because these are mapped to different priorities that have been set by ONC. Next slide, please. At the same time we published USCDI version 4, the final, we opened up submission for USCDI version 5 for the draft. Now, that's a 60-day period where anyone can enter in a submission for a data element that's not already in USCDI, or they can also enter a comment on something that has been submitted to maybe provide some more information. Maybe something has changed in the past. Maybe there's a implementation guide that now supports that data element, or there's some implementations that someone would like to let us know about. So we have until September 20th, midnight Eastern time, for those comments and those submissions to be entered. Now, if you remember a couple slides ago, we had those icons next to the data elements. These are priorities that are set by our national coordinator to help us evaluate data element submissions. So we look for data elements that support the, I'm going to say, the advancement of addressing healthcare disparities and equities, underserved communities, behavioral health integration with primary care, was a priority that was added for USCDI version 4. Certainly, public health is always a priority. And then we look at key additions over past versions. Maybe we're building up a data class, and I know I haven't defined what a data class is, but attend our September 28th tech forum and you'll hear more details. But we added 6 elements related to laboratory in USCDI version 4. And of course, we also look at it, we certainly review comments from folks who might want to let us know just how difficult it might be to implement a data element that we're proposing. Or maybe they'll say, hey, this one's really easy. We can do this one, no problem. Next slide, please. So now we're going to talk about our online submission system. Because another thing that we use to evaluate data element submissions is what we call level criteria. So we've got the priorities set by the national coordinator, and then we have these level criteria. So we look at these different aspects of a data element, different things like, is there a standard terminology identified for it? Is it referenced in specification? Is it already exchanged? Things like that. So one of the big changes we made when we released version 4, we also made some enhancements to make these criteria more visible and more transparent, because previously you had to actually go in to start a submission before you could see what these were. So next slide, please. So if you look at any of you who've gone to the website, you'll see that there's the different USCDI versions, and then there's these levels, level 2, level 1, level 0. So they're represented on tabs, and on each one of those tabs, we've now added the text that says, this is how ONC has decided how to place a data element on this level. Level 2 is considered the highest level and the most likely to maybe make it into a draft USCDI for the next version. Level 1 is one down from that, and then level 0 is the lowest. Next slide, please. So this is just a screenshot of what the tab text would look to explain to you what the leveling criteria are. Next slide, please. And next slide. Oh, on that previous slide, I should call out, we used to call, thanks, Susan, level 0, it's now level 0. It used to be called comment level. And we had in response to some internal and external comments, or feedback, I should say, we changed it to level 0. Thanks. Next slide, please. So another change we made in the submission form is that we used to ask for a data element description. We're now asking for a definition. And they're two very different things, and it's an important distinction. So we really would like to see a concise, clear definition for the data element that you're submitting. There's plenty of opportunity in other parts of the submission form to provide use cases and examples and things like that. But we're trying to help folks think about, what would you, if you were to look this up in a dictionary or a thesaurus or something like that, what would the definition be? So that's another change I'd just like to call out. Next slide, please. Quickly, next slide, we'll go over the USCDI timeline. We've talked about this already a little bit, so let's move on. And then here's the response to a question we got ahead of time, where someone was trying to understand, what is the definition of electronic health information? And is there any way you can make that bigger, Susan? I'm having a hard time reading that slide. I don't know if it's small for other people. I don't think you're full screen. Oh, that's helpful. So EHI is any data that's maintained in electronic media or transmitted by, well, health data, health information, or transmitted by electronic media. And just to move us along a little faster to get to the question and answer period, if you would click on that link over on the right that has 3 asterisks after it, Understanding EHI infographic. This is where the relationship where at one time EHI was defined as USCDI data elements, and then it grew to include all information in the designated record set, and then it's grown since then. So I just wanted to provide this for the people who were asking this. The slides are available on the Confluence page, so you can go take a look at this at your leisure. And on the next slide, I provided a definition of a designated record set because it all kind of goes together.
There we go. Okay.
All right, that's it.
Lovely.
All right. So any questions on that or any questions in general? We're on to the Ask the ONC part.
Yeah.
I'm curious about your path. Oh, go ahead, Lisa.
Oh, you go ahead, Linda.
I was just going to say, I'm curious about your path for USCDI Plus. And I'm assuming that none of that goes into sort of the C-CDA space, but I'm curious how you're thinking about that.
I might punt that one over to Matt.
So you're asking whether or not we're thinking about, in terms of USCDI Plus data elements or sets, you're wondering if we're thinking about C-CDA at all?
That's part of it. I'm just trying to understand in general with C-CDA, like we've seen the C-CDA Plus quality. Is there any sort of roadmap around the other pluses that will be coming out? And then the last part was, will any of those impact C-CDA, or is that just USCDI?
Yeah, so you said USCDI Plus, or you meant USCDI Plus quality. So I will answer your question and then see if Kyle has anything to add. So with USCDI Plus, our goal right now is very much focused on a lot of them are, the initiatives are focused on the data modernization initiatives that are happening in different agencies, so like CMS and CDC, and that is moving to FHIR. So right now it's not what's being discussed is like, how do we move from, for example, quality from like QRDA to FHIR, QDM or DQM. I forget the name of it, but Kyle can confirm. So mostly FHIR related for all the initiatives that we're working on so far. We have not discussed it being brought to C-CDA or making like updates based on C-CDA. I think that's something we could consider, but we're very much focused on FHIR, moving towards FHIR. And Kyle, do you want to add anything?
Yeah, I think you nailed it, Matt. I think the only other thing that I would just include is just sort of the regulatory perspective, which USCDI Plus quality, unlike USCDI, is outside of regulation. And so I think that's just so within, it makes it different, and within each of the domains, whether it's USCDI Plus quality or cancer or public health, those projects are specific, as Matt said, to modernization. So if there was any type of regulatory change for those areas, it would then have to go through a cycle, and there would be more information way down the line. But I think, in general, I can say that, for all of the USCDI plus projects right now, there are no, C-CDA crosswalks, or it's not even a crosswalk, but implementations.
Thank you.
Hi, this is Lisa Nelson. I was going to ask a question about what ONC could do to help us move the industry forward as we are making continuous improvements to document types like discharge summary, which we would like to see have greater uptake. Specifically, I wanted to ask about changes that will likely be balloted in January 2024 and published in early spring or late spring or early summer 2024. And if it would be possible for ONC to preemptively or proactively start allocating and budgeting funds to have the testing tools like the CDA scorecard and I think it's called the site testing tools that people use for consolidated CDA documents, upgraded so that testing on the changes that will be made to the discharge summary document will be rock solid as we bring this new implementation guidance out in the spec that'll be published then. And then besides funding testing tool development, if there's anything that can be done from a promotion point of view to highlight changes that are going to be coming with consolidated CDA. As you know, this will be the first time since 2015 that we've really been able to address hold for future improvement kind of tickets. We've only been handling errata for so many years, and now we're going to be able to make some substantial improvements. And I'm just wondering what you guys could do to help get the word out to the industry that and encourage use of other document types, not just patient summaries, to get the job done better and to sort of wake up and realize that there's going to be changes and improvements that should be on their roadmap for incorporating.
Yeah, so I'm happy to start the response, Lisa, and Matt, I'll let you follow up if I've forgotten anything. But I think, in general, we do now have a pretty good predictable process for updating C-CDA validators on site on an annual basis through the SVAP program. So, as the C-CDA companion guides are, rolled out, aligned to, updated versions of USCDI, and even before that happens, at ONC, we are already looking at that and working with, Brett Marquardt and folks to, get the validators updated. And so that there is that, sort of annual, update. In terms of the IG update, I think, that's something that we can certainly put through SVAP and would be then, something that we would be able to, update our testing tools to support. Again, I think that, it sort of goes back, and I don't want to get into like the regulatory mode, but in order for criteria to be updated in like conformance criteria, we would have to, any changes to those standards would have to go through a regulatory update, which, is, years in the making. But, that said, there's also that, avenue outside of SVAP. Does that answer your question, Lisa?
Yeah, it just sounds, I guess it sounds like the regulatory update becomes a gating factor for you guys to be able to help push the industry forward. They can certainly move forward on their own through the SVAP process.
Yeah.
But it seems like there's something that you guys could do to help at least make people more knowledgeable at a higher and supported level to encourage them, if they do want to move, that there's 10 better things if you were to start implementing discharge summary, you know, that we're really working hard to make these standards better.
Yeah. I mean, I think, you know, that's a really good point. I mean, we do a lot of developer workshops. We do run educational programs. And I think, you know, we could certainly do some sort of a program educational update in conjunction with, you know, SFAP to really alert and sort of promote it, if you will. I don't know if promote's really the type of word that I should be using. But,
educate, maybe educate,
highlight.
at least get the word out. Yep.
Right. Yeah. I mean, I think that would certainly be, you know, something that we could do. And then the other thing that I just thought of, that's just worth sharing. I don't know how much people actually know about this, but we have, it started this past spring, but we are revamping the site tool. So all of the sort of information architecture and the way that that website looks and feels, which is, I won't even use it. I can't think of an adjective to describe it in its current state, will be revamped. And I don't have the timelines in my, you know, in front of me right now, but I think, you know, there will be changes coming to site tool in the future, which I think will also be a way to sort of show the public, you know, ONC's commitment to having, you know, validation tools that, you know, are, you know, usable and easy to access, et cetera. And also another place where we can sort of highlight some of this information.
Do you feel like input from the IAT community has been taken into consideration on how, you know, what revamping changes might be most beneficial?
Well, funny you should ask, because there is a whole, you know, part of it is a, you know, focus groups. Part of this contract is to run, you know, get that feedback. And I, you know, having left tools and testing, this was something that I, you know, was under my purview. It is no longer, but I can go back and talk to the PM on that project and make sure that the IAT is engaged in this process, because of course you should be. Yes.
Absolutely. That would be wonderful. And you can contact through the CDA management group, and we'll help with the timing and help orchestrate getting that kind of feedback. But I know many of our community really use those tools, and when they don't work, or, you know, that it just slows down their development, and we'd love to contribute.
Okay, awesome. I'm sending an email now.
So,
thank you,
Lisa. We always accept input. Anytime you can reach out to us, you know, and I think we've talked many times about having a formal process of how, you know, you all would like people would be able to submit issues that they're having, and then it could, like, we could all see that in a public way. Not sure if that's been utilized as much, you know, as like similarly to like the chat.fire.org, the Zulip. I'm not sure how much Zulip is used on the C-CDA front, you know, but that's something potentially we could, you know, look at finding ways to better make it easier for us to get feedback from you all, other than like twice a year at an IAT. We're definitely paying attention. We're here. And we want to,
I
like,
know it's just
you know,
about timing. So if you know, you can make a good comment, you know, 3 days too late, and then it just can't have the same impact. But if we're making comments at the right time to influence that project at the right time, that would be the best.
Yeah. And you know, the scorecard is updated like as we update the C-CDA validator as well. So, like, you know, but there are things that, you know, if we updated the C-CDA rubric that we published a long time back now, that could be another way to help improve the data quality issues. You know, I think that's something potentially to look at. And while I can't, like, always confirm funds available to make updates, you know, we could definitely do our best and work with our tools and testing team to figure out a way to provide that support to make updates based on additional rubric that are created based on best practices. And the scorecard, I see Jessica's chat. Is the scorecard API not working right now?
No, not, it hasn't for a while. There was some communication that came out a while back on the Google group that said, it was going to be taken offline. It seemed like it was going to be taken offline essentially permanently, but then they asked for if anyone had like a special case or a need to leave it up, to contact them, and we did, because we have it integrated into our software as part of our certification process. And so we had requested, we were instructed to request API keys, and so we did, but we don't have them yet. So it's just sort of dead in the water at the moment.
We'll definitely follow up on that. I think there was some confusion around the note that was sent out. That was around the one-click scorecard, which is, sending a direct email to, scorecard@direct.healthit.gov or whatever it is.
Well, there were 2 emails. Sorry, Matt.
Thanks, Rachel. That's all right.
There were 2 emails that went out. One went out about the one-click, and the other one went out about the scorecard, and it was very confusing. And we were wondering if it was the back end of the other one or something, of what's going on. Why would both be affected?
Yeah, so I will follow up on that and or Kyle, would you do me a favor?
Yep.
And follow up on that for me?
We'll
do what we can to maybe send a note to the Google group, but I'll let you all know so there's no immediate plans to pull anything down at this very moment.
Yeah.
So
and just
so we just need to get ours working, I guess, is the problem. And then we were told we need keys to make that work. Okay.
Yeah. And just to confirm, is just the scorecard API that's down, or the whole thing?
The API.
Okay, thanks.
We use the API. Yeah.
Yeah, I feel like I'm having a deja vu. I think I've had this maybe the last time I was on the IAT. We
Yes, that's correct.
Conversation back.
That is correct. Yes.
Okay, good.
And
I'm not imagining that.
And
there's a very I'm sorry, Linda. There's a very fundamental design issue that I think affects where we're at with CDA. We're at a point right now where people are trying to be more innovative, where they're experimenting with doing things that aren't against the rules, using some of the open template capabilities, choosing to add sections that maybe the document template didn't even think to say may be there. And unfortunately, the validator works in this really limited, sort of rigid way, as if the only thing that it should consider is what the implementation guide says. But all the templates in CDA are open templates. And if someone thinks of a good idea to help eye care, and they want to start adding an additional section into a progress note, the validator should know by the template asserted what section that is, and then by the template asserted of the entries, what entry it is, and be able to validate and score documents that go outside of the lines of just what the template in the IG says might make sense. And I think that the previous developers didn't take that more open stance, and we're at a maturity level now where people are starting to be ready to be more creative, and we need the validator to be designed in a different way.
Yeah.
Thank you, Lisa. I want to also make a comment that in the optometry space, we have vendors, and I'm not going to mention names, that will not put optometry in because it fails. And if it fails their scorecard. So this is a real inhibitant to us as in an optometry space, because we want to be able to send refractive data. If you want your eyeglass examination information sent to another doctor, we can't do that today. That's a simple, basic concept of data that we are unable to move.
This is Rachel. I have sorry, Robin, were you done? Or does ONC want to reply to that?
Yes.
Okay. Okay, I think you're following up on what Lisa's saying. Is like the industry, the specialties are coming to the table at this point, and they need their data supported as well. And I think the eye care industry's definitely taken, the bulls by the horn to get that done. So hopefully we'll make some movement there, and through the CDA management group, hopefully we can help with the scorecard and ensure that it's able to do the things that other groups coming to the table need to do. I have a specific question that's not specific to C-CDA, but it is about ONC certification on G10. Anyone in the industry that has a G10 certified API, if an app company comes to the EHR and wants to connect, but there is not a physician or a patient requesting to use the app, does the EHR have to connect the app?
Is the EHR?
Last I checked, this was a C-CDA. I'm
Yeah.
just messing with you, Rachel. So I don't want to. I don't want to answer the question unless.
Okay, so you don't have to today, but where do we go to get the?
Can you send me an email?
I will, but I've got like lots of vendors that need answers, and there's a war going on, and I don't know if y'all are aware of it, between the APIs and the apps, and I just want to be that in-between person.
Yeah.
So tell me where to go.
Yeah.
Okay.
Can you do me a favor? I'll put a link in the chat. This sounds like something we should have, or you probably should write an inquiry on our health IT feedback.
That's exactly what I was going to say, Matt.
Exactly, that I can just point people to. Yes.
Yeah, and I would
can you you have that link, right?
Rochelle, and I'll just say for everybody, the way that we really I mean, it's great to talk to us, and we can answer questions and we can try to do things, but like with specific issues like that, the more they can go into inquiries, they are, they're vetted, they're logged, they result in more and tangible action. So I really, just can't underscore using that enough.
And I agree. And we've put in queries, and what happens is you get redirected back to the final rule, or you get redirected back to definitions of what an API user is, and there's still a very gray area there seems to be right there.
Stick on them. Keep asking the questions because it's all logged. You don't, it's not a one and done response. And if you don't get a response that's satisfactory, just keep asking.
Okay.
Yeah, and
thank you.
You know how to get a hold of me.
Yeah, I'm just trying not to bother you. I know you got trying to give you some space.
Don't, it's okay.
No. If you've asked a million times and haven't received a response, you can get a hold of me.
Okay. All right. Thank you.
They have a big team. They can have 8 people asking a million times.
Yeah, I mean, you can see that the debate there is like, well, we're supposed to give data for patients and providers to have access to the data. How do we, not everybody's a bad actor. They're just trying to give access to and make sure there are apps out there for people, but it's just a very big unknown. So I'll take it offline and follow up, and hopefully I'll have an answer next time we meet.
I'm trying to make sure that Linda Michelson's question is answered.
Yeah, I think I asked it wrong. I was asking, what I was talking about, Matt, was the direct trust email into the validator. And you say no one is really using it. And the main reason I think...
Don't say you, please. I didn't say that. Sorry.
What did you say?
Go.
I didn't
said, don't
understand.
say it. Don't pick on me. Don't pick on me directly.
I'm sorry. That's what I heard you say. But the direct trust, the reason it's not very useful is it doesn't give you back much except kind of have your EMR do something about it. But the report that you actually get out of that validator is awesome. It needs to be able, trust email needs to include those details, because then they say, I've heard it said, not by you necessarily, Matt, but I've heard it said, well, it's just, we think it's not going to be the people that know how to solve the problem that's sending this in for validation. So we give them that lightweight response. But that heavyweight response gives the people that send it more to walk through with their vendor to get exact changes made. So I think it would be used much more if you gave them that same level of detailed response that you do when you're submitting the non-PHI data, or if you locally instantiate it and use PHI data.
And to underscore that, Matt, we have asked the same request for at least 4 years.
and we have provided the rationale for why the other report is the report that people want. And we've been very clear about that request. And it would cut down half your work because you only have one report you have to make. We don't need the other type. And
Yeah,
somebody thinks that we want something different from what we actually want. And in this IAT, we've been providing that feedback.
Can you do me a favor and put together a request that's coming from all of you and send it to me?
Yes, take that as an action item from the IAT.
I got it.
Yes.
I'll take it. All right.
We can draft it in CMG too.
Yes. Yep. And along those lines, for all the ONC crew that would be at the upcoming working group meeting, the CDA management group compiles a list of high-level issues that we are hearing about and believe will be a priority for the coming year. And we put that list together. Dan Vreeman comes to our Monday Q4 meeting so that we can present and summarize some of those things. But we would like to invite as many or the right ONC representatives to come hear that feedback and rationale, so that as you think about things to be funded in the coming year, you've got the information that's consolidated by the management team to take into consideration. Would there be ONC members that could come to the Monday Q4 CDA management group meeting?
I will go to it. Yes, at minimum.
Okay, you're invited. Thank you for coming.
Awesome.
Awesome.
Duly noted.
And then for the folks in the chat, there is a way to leave a comment if you don't log in. It's like at the bottom, right below where the login is. So you can leave a comment without logging in, but
yeah, I got you covered.
In, you know,
there's a little link under the
just wanted to
password
confirm.
or
Thanks,
something.
Matt.
Got you covered.
Yeah. But overall, I hear you all. We'll see what we can do.